Chetan, are we live?
No, ma'am, just wait. Yes, ma'am, we are live now. Over to you.
Yes. Good afternoon, all the delegates. On behalf of Linux Derma Science, I welcome you all for this conference. First of all, I would like to thank the NSI for the opportunity given to us to do this program. This is a continuous program, and definitely we will be the partner throughout this year, not only this year, in coming years also. And as far as this Linux is concerned, Linux Laboratories Limited, based at Chennai, is a 15-year-old company having a strong presence in neuropsychiatric division, neuropsychiatric segment. And we have now reached the 5th position also in some of the markets, and almost all the neuropsychiatric doctors in India knows about Linux Laboratories. Now we are venturing into derma, and we have acquired one South-based derma company, and who is having a presence in Tamil Nadu and other states for the past 10 years. And Linux Laboratories having two manufacturing sites, and definitely we will be the good, actually the scientific partner for dermatology. At the same time, we are having a lot of plan to introduce newer products in the coming days. And we are having association with 30,000 healthcare professionals, and 30 million plus families are getting a benefit through our portfolio of our products, and more than 1,000 distribution network, which gives a better availability. At the same time, more than 800 families are associated with Linux to make this task successful. And as far as the products are concerned, we have a very good product range. In fact, Active MF is the one of the moisturizer from Linux Derma Science, the combination of hyaluronic acid, shea butter, and aloe vera and vitamin E. And the benefit about this Active MF is it is a micronized particle which will give us a better penetration. At the same time, we do have very good product like Oxytan, which is a non-steroidal formula for long-term use in the management of melasma, choloasma, hyperpigmentation, as well as the dull skin. The first time we have introduced this oxyresveratrol combination with the niacinamide, and we do have High-Tech, which is again a first time in India product, the novel anti-aging formula with a combination of Oxylate 4%, which is a reserved molecule from Silab and France. And also we do have hyaluronic acid, vitamin E in shea butter and High-Tech. So smooth and radiant skin, High-Tech is the wonderful formula available in Indian market now. We do have very good product like Acne Stall face wash as well as bar, which is enriched with bioextracts for acne-free glowing skin. There are multiple products available, and the due course we will be presenting other products also. And this program is very interesting, and Onychoscopy, the skill-based CME series first program. And we assure you that in the future course of all the NSI's program, Linux will be a partner. And today, first program and next program again fixed on July 3rd. So with this, I thank everyone for the opportunity and sparing your valuable time for this program. I hand over the session to Dr. Khushbu Mahajan, who is a practitioner in Delhi. Thank you, sir. Thank you, madam. Please take over.
Thank you, Mr. Venkatakrishnan. Yes. So good afternoon and warm greetings from NSI. Myself, Dr. Khushbu Mahajan. I'm Treasurer NSI, and I extend warm welcome to our respected faculty members and our delegates. We hope that all of you and your loved ones are keeping safe during this pandemic, praying for everyone's good health and speedy recovery. As NSI, we are proud to announce the initiation of skill-based CME series with the help of Linux Derma Sciences. And today we proudly bring to you our first skill-based CME on science and art of onychoscopy. So with this, I request our president, respected Dr. Sushil Tahiliani, sir, to give the welcome remarks and inaugurate the CME with his blessings.
Thank you, Khushbu. So I begin by offering warm greetings to everybody who's attending today's webinar. You know, as a study of nails, we all were taught in the undergraduate days, but all it led was we had to look at the clubbing, koilonychia, color, whether the patients had pale nails or cyanosis. In short, a little bit about general health, but we were not taught anything about the great significance of what the examination of nails can reveal. And things did not change much earlier at the postgraduate studies, because even in dermatology, nails got a short thrift. You know, they were kept as an optional subject, maybe worthy of a short note. But things changed luckily in the last 2 decades, and we know that study of nails has taken a quantum jump, and we know how the study can enhance the way we diagnose conditions, the way we manage, and also interventions in nails have been taken over by dermatology. Things have also changed in India thanks to the initiative taken by our pioneers, Dr. Archana Singhal and Dr. Chandra Grover, who started the Nail Society of India way back in 2012. And this definitely increased the understanding, and we had more propagation of the knowledge about nail diseases, and we had more younger people who were initiated into the subject of onychology. Now, coming to today's topic, we all have learned to use dermatoscopes or dermoscopes. And today, our learned faculty, they have taken great pains. They will teach you about what are the basics of the instrument, how to choose an instrument, how to modify it, and what precautions to take while studying nails so that you get optimum results. They'll tell you about the polarized, non-polarized. They'll tell you about the handheld versus the greater magnification attached to the laptop. They will also tell you as to how we can diagnose some conditions with confidence without any further interventions, and they'll tell you about how this can be used during surgeries. And I'll request you all that in the times of COVID-19, the amount of effort the faculty has taken, it will be worthy if you all participate actively, you ask your questions, you take the carry home messages and implement those in your practice. And more so, I'll request you all to join the Nail Society of India if some of you have not done so, so that we can take this subject further. And with these few words, I hand the mic over to our Master of Ceremonies, Dr. Khushbu, to conduct the proceedings.
Thank you so much, sir, for your kind words. So without wasting much time, let's begin with our first session, which is live demonstration using an onychoscope. So I invite Dr. Deepak Jakhar, who is the current Joint Secretary of NSI and also co-founder and medical director of Dermosphere Clinic, New Delhi, who would take over the proceedings of this session. Over to you, Deepak.
Thank you, Khushbu ma'am. A warm welcome and very good afternoon to all of you. So we'll be starting with a live demonstration of the science and art of onychoscopy. And for that, we have a very experienced and very young faculty who will be telling us about the various dermatoscopes which can be used for onychoscopy and how to use those particular dermatoscopes specifically for the nail. So for the first demonstration, I would like to invite Dr. Arzoo Mishra, who is a senior resident at United Institute of Medical Sciences, Prayagraj. Dr. Arzoo will be telling us about the various components of the USB dermatoscope. Over to Dr. Arzoo.
Thank you, Deepak sir. A very good afternoon to all. I will take the USB, the video dermatoscope or USB dermatoscope, and mainly I will tell about the instruments, the parts, and the basic instrumental features. So starting it, there are basically, as we know now, the dermatoscope is a very useful diagnostic tool in all the skin diseases. Similarly, it is also a very useful tool in the diagnosis of nail diseases also these days. And there are two kinds of dermatoscopes. One is the USB dermatoscope, in which the magnification is very good, the resolution is not that good, but the magnification is very good. In case of handheld dermatoscope, there is resolution is good, but the magnification is not good. So coming to the video dermatoscope, that is USB dermatoscope, as this I am holding this in my hand. This is the USB dermatoscope, and why it is known as USB dermatoscope, because it has this is the cable which is connected to this dermatoscope, and this is the cable, and the one end of this cable is connected to this USB dermatoscope, and the another end will be connected to the computer, the laptop. And now coming to the other parts, if we'll see, there is a sensor which is located, the finger sensor. That's how we click on this. We touch this finger sensor, and that's how we take the image. And so we can do that by single click, or we can do that by double click. That we can go in the setting, and that we can set in the software that we have what we like, either a single touch or double touch. And now coming to the other parts, this is the dynolite dermatoscope, and this is the it has metallic body. And now coming to the most important portion of this instrument, the most important part, that is this magnifier. And as you can see, there is marking which is shown in this. That is the magnification, that how much magnification we are going to do the onychoscopy. And when we move this, the simultaneously there is movement of the camera also. When we move this, there is movement of the camera with this, by which the distance from the surface changes, and then the magnification and the view also changes. And now coming to the other part, this is the polarizer. In this is, as you can see, this is the polarizer, and this is the plus sign shows that there is polarized microscopy, and this minus sign shows that it is the non-polarized view. So polarized view we used when we have to see the deeper structures like vessels or capillaries or deeper pigments and melanin, whereas the non-polarized view is mainly used when we are looking to the superficial structures like scales, keratin. In that case, the non-polarized view is better. So as we change this from plus to minus, it goes from polarized to non-polarized. Now coming to the other part, as we can see, as this is the camera of this dermatoscope, which is movable by the use of by rolling a magnifier. When we roll it, it moves. And there is also there are also LED lights which are located in this area. So for its functioning, like when we connect it to the computer, then the LED lights get on, and then using that light we are able to see any field. And there is also film, the polarizing film, which is covering the LED lights. When we move this polarizer, the position of that film changes, and which causes the non-polarized view to polarized. And and now coming to the face plates which we used with this. So there are various kinds of face plates which are there, and those face plates gives different magnification and the different view. There is always, so I'm showing how to connect that face plate. That is how we connect. And when we and there are different kinds of face plates which are available, like this one is which we commonly use. And This is the slightly longer one. It has only one magnification. The rest, all other plates has two. There is two magnification. One is the lower magnification, and another is the higher magnification. So first we can use the lower magnification to see, and then higher magnification. This is another faceplate. So that is how we attach the faceplate, and that is how we detach the faceplates. For the rest, how we connect, it will be covered in the next session by Dr. Vishal. And there is also fixing knob, which is also available with this instrument, by which we can fix it, and which can help in easy handling and taking image. Now,
thank you, Dr. Arzoo. So there is one question for you. Does the software which you were talking about, does it come free with the dermatoscope, and how to install it?
There are two ways to install the software. There is one CD which comes with the instrument itself, and in that CD, from this CD, one can install the software. And there is another ways one can, like, this is the Dynolite, Dynolite dermatoscope. One can go on the Dynolite website, and one can install the software from that.
Okay, just one last question for you. Can you attach this USB dermatoscope with the phone as well?
Yes, we can attach. We can attach to the phone as well.
Okay. Do we need any specific additional requirements for that?
Yes, there is some. There will be additional connector which can be used, which will be between this and the phone.
Okay, thank you so much. Thank you, Dr. Arzoo, for the very elaborate description of the instrument. Now to check how to use this instrument on the nail, I invite Dr. Vishal Gaurav, who is a senior resident at All India Institute of Medical Sciences, New Delhi. Dr. Vishal will be demonstrating how and what features we have to see on the nail with the help of a USB dermatoscope. Over to Dr. Vishal.
Good afternoon, everyone. I would like to take this opportunity to thank the Nail Society of India for having me here. So without wasting any time, so as the components of the videodermatoscope has already been discussed by Dr. Arzoo, we'll try to learn how to use it. So first of all, before starting onychoscopy, we need to ensure that the hand is positioned properly. So the undue pressure should be avoided both from the examiner as well as the patient. And this is especially true when we're trying to examine the vasculature. The hand should be at the level of the heart, and the ambient temperature should also be maintained. The nail plate should also be cleaned thoroughly with acetone or spirit to remove the debris, dirt, or external applications. So now before doing onychoscopy, it is a logical approach to go in a sequential manner so that we don't miss any area. So generally we start from the proximal nail fold, then we go on to the lateral nail folds, and then we examine the proximal nail plate and nail bed, the distal nail plate, nail bed, the free edge of the nail, and the hyponychium. So I will be starting with the onychoscopy of the proximal nail fold. So as you can see that I have placed my dermatoscope at the proximal nail fold. This is the non-polarized mold. As we can see the surface structure as well. The light is being reflected from the surface, and in this mode we can see the changes in the upper layers of the epidermis. What we can also see is that the cuticle is well adherent to the nail plate. Now this is at 50x magnification. In the same field, now I will polarize the light so that the changes after polarization become more visible. So now we all can see that the nail fold capillaries can easily be visualized, which are regularly and evenly placed. This will become more clearer when we shift the magnification to the higher one. So now I will be changing the magnification to 200x. So now we can see the loops of the capillaries, which are regularly and evenly placed. Now this visualization can be enhanced by using an immersion fluid. So now I will apply the immersion fluid so that you can appreciate the change. So now you can see that after application of the immersion fluid, the nail fold capillaries have become much more visible. This is because it has further reduced the reflectance of the light, allowing the polarized light to reach up to the upper layers of the dermis. Now similarly, now we'll go on to the proximal part. Now we'll be examining the proximal nail plate as well as the nail bed. So I'm changing the magnification back to 50x. And I'm changing the polarization as well. So this is the non-polarized mode. We can see a shiny nail plate with longitudinal ridges. After changing the polarization, now we can see the lunula very distinctly, as well as a uniformly pink, nail bed. Similarly, we can go on to the higher magnification, that is 200x, to better visualize the nail bed changes. Again, this examination can be augmented by using an immersion fluid. After examining the proximal nail bed and the nail plate, we go on to the distal nail plate and nail bed. So on examination, again, we change the magnification to 50 and the light to the non-polarized mode. Again, it is clearly appreciable that the surface changes are very well delineated in the non-polarized view. Now, if I change the polarization, the surface changes become very less visible. We can also appreciate few longitudinal capillaries which can normally be found in healthy nails in the distal nail plate. When examining the distal nail plate, we also have to look at the onychodermal band, as this gets disrupted in many conditions leading to onycholysis. Then we go on to examining the distal nail plate, the free edge of the distal nail plate. And we look for the thickness and the pigmentation in the distal nail plate. The examination of the hyponychium especially poses problem, as we have to manipulate our dermatoscope back and forth to bring it into focus. Now is it clearly visible, and we can appreciate the distal nail plate, the free edge of the distal nail plate. in examining the hyponychium, again, we have to use both the modes. So in the non-polarized mode, we can easily appreciate the normal dermatoglyphics, which can be lost in many diseases. And in the polarized mode, normally we do not see any vascular structures. But in diseases such as psoriasis, we may see vascular structures which can help us make the diagnosis. Now, I would also like to tell you how to capture the image. So once you have put in your dermatoscope, you can click at the plus sign, and then you can type the name of the patient or the patient ID. And then you can click on create. So this creates a folder where your subsequent images are saved. And this, when you install the software, it already creates a folder, which is by the name of the company. For example, this is Dino Capture. So you can click on that and you can easily retrieve the images.
Thank you, Dr. Vishal. So there is a question for you from Dr. Shivani Bansal.
Yes,
what is the model number that you are using for this dermatoscope?
Yes, sir. What?
What is the model number of your dermatoscope? Dr. Shivani Bansal wants to know.
So the model number is AM73915MZT.
Okay, thank you. There are some questions on the vascular loops as well. We'll be taking a separate skill-based CME for the nail fold capilloscopy. So we will include all the questions related to the nail fold capilloscopy in that session. Now I would like to invite, Vishal, if you can please stop sharing.
Yes, sir.
Now I would like to invite Dr. Jayasree Puravoor, consultant dermatologist from Medical Trust Hospital, Kochi, Kerala. And Dr. Jayasree would be speaking on contact dermatoscope, the handheld contact dermatoscope. Dr. Jayasree.
Ma'am, please unmute yourself.
Hello, am I audible?
Yeah, you are audible, Dr. Jayasree. Over to you.
Let me just my screen. Can you see my screen here? My PowerPoint here?
Not yet.
Not yet.
I mean, bottom there is a share screen option. First, click on
Yeah,
that.
no. What happened was okay, yes, I got it. Now, can you see
Yes,
my
now
screen?
Yes.
Hello, everyone. Good afternoon. At the outset, I would like to start. I would like to thank the Nail Society of India, the Linux, for organizing such a wonderful academic activity. So, as we have finished the demonstration of the video dermoscope and the use of a USB dermoscope, let's see how we can use a handheld dermoscope for the purpose of onychoscopy. So there are a few caveats with using a handheld dermoscope for the purpose of onychoscopy. As Dr. Vishal had originally mentioned, the dermoscope by itself has a lower magnification, and it is essentially a contact dermoscope, most of them by its make, but then it is quite convenient. It is a pocket instrument, and the ease of use makes it very versatile in its functions. And various attachments are possible. The designated dermoscopes comes with specified attachments, and you can use your mobile phone, your compact camera, even a higher DSLR camera, and by that you can improve the quality of your images. So the essential steps remain the same. We go by non-polarized, polarized view, and an ultrasound gel is usually preferred as the immersion fluid. And what I use is a Dermlite DL4N connected to an iPhone 6s camera. So let's just go about a video of how it is used in a patient. So the first step is cleaning the nail, and there's one thing I always carry around or keep in my OP. It is a nail polish remover along with, because often when the patient comes, there can be exogenous pigmentations, which the commonest one being a nail color, and that can seriously interfere with your onychoscopy findings, and asking the patients to come back after removing it's always it doesn't look good. So along with this, I always carry or keep and reserve a nail polish remover. So after cleansing the nail, so this is my DL4N and Dermlite, and this is a iPhone S camera. So what you can see here, this is a designated attachment for this that comes with the Dermlite. There are different attachments, and there is also a universal attachment available for the Dermlite series, and many other handheld dermoscopes come with the same option. So here, this is a magnetic attachment. So all you need to do is just to keep it, bring it close, and it will get perfectly attached. And there is a toggle switch on the side of the. So there is a toggle switch on the side of the dermoscope, and here is a point which is marked 0, which is usually where the focusing starts in the dermoscope. So you open the phone camera, you attach it with the dermoscope, you switch on the side light, and then focus on the screen. So this view is a non-polarized view, and the side switches, by the side switches, you can toggle and make it a non-polarized view as well as polarized view. So first, what we are viewing now is a non-polarized view. So you keep it, and according to the magnification that you want. So the dermoscope per se has a 10 times magnification, but then using the magnification of your phone or whatever camera that you are attaching, you can increase the magnification and view it accordingly. So this is how a non-polarized view is taken. And now while toggling the switch, it changes to the polarized view. And here we are taking the polarized view, just like taking any other image. Touching the screen focuses the view of the nail, and then what you need to be careful is not to press it too much, because it's a contact dermoscope. See, now you can already see the blanched appearance compared to how the nail as such was pink before. So this is a blanched picture where the excessive pressure comes, which should not happen. And according to the area that you are taking, you change along with the convex nature of the nail, and you focus that area of importance and take appropriate images by adjusting the area as well as the magnification. So right after taking, you can view the images that you have taken. So this is how a non-polarized view appears. The surface changes, you can see, this is a normal nails actually. My nail, you can see small ridges, the surface ridging. And here you can see the polarized view where the surface changes disappear, and you can see the pink nail bed underneath. So this is the least zoomed out version of the non-polarized view. Here, this is the blanched appearance that we spoke about. So when there is excessive blanching, you can see a yellowish color, and see how the nail bed is completely pale, but you can see the vessels that is present at the onychodermal band, the normal vessels. So when you press here too much, there will be blanching, and that can lead to distortion of findings. which shouldn't happen. And the dermoscope should be adjusted to focus the relevant area. So here the pigmentation and the nail changes are here. So you attach, you focus and you adjust the position of the dermoscope in such a way that that finding area comes into the focus, where the remaining area may remain out of focus. And here there is how we use a ultrasound fluid before using the dermoscope. An ultrasound gel is preferred because, as you can see, how it stays, it doesn't run away. It's not too liquid and it doesn't run away. It stays on the nail, and excess of it can always be wiped away. And then the same process. Essentially, we use a polarized view while doing using linkage fluid, and it improves the vision of same way that we saw in the video dermoscope. It improves the findings. So here, this is an example. This is how a vasculature has appeared in a polarized view without linkage fluid. And here you can see how the presence of fluid has improved the appearance of the vessels. You can pick it up better. And this is a magnified view. Now, another advantage of some dermoscopes like this is that you can remove the surface cover of it. So essentially, you can turn a contact dermoscope into a non-contact way, especially if you are concerned about the if you are concerned about the blanching and there is excessive pressure that is caused, you can remove it, and that way prevent blanching caused by the approximation of the dermoscope, and you can appreciate vascular features better. The only thing is that focusing is a little tricky, and you should be careful that the rim doesn't get pressed onto the finger edges too much, which can result in distortion of findings. So here also, according to the area of interest, you change the focus and magnification and click the images. So vascularity, you saw how good it is with a USB dermoscope because of the high magnification. In using a handheld dermoscope, that is one factor which is always compromised because of the low magnification and the contact nature of the dermoscope. It is difficult to do capilloscopy as good as in a video dermoscope. Another view that is important is a end-on view, where you ask a patient to lift the finger and stabilize it in a slightly raised part, and you take an end-on view of the nail scene. And this is important. This step should not be missed, so that you capture whatever findings are there. So there is the difference in scene in different conditions, the compact nature and the ruinous nature, which shows how end-on view is important. So this is just an example. We can see how the surface changes, the nail bed changes, and the end-on view of a nail, afflicted nail is captured on polarized dermoscopy using a handheld dermoscope. Okay, this is one technique that I always use, because when we are taking individual nails, especially in multiple nail involvement, it is difficult to later on, especially in a handheld dermoscope, you need to categorize and catalog the images yourself. You don't get a software. So later on, this is for a ease of cataloging images. We put dots. The right hand fingers are put dots from 1 to 5 from the little to thumb finger. And for the left hand, we use blue. So either before starting the onychoscopy or after, before starting the onychoscopy, you put finger dots around the nail, so that when you are using the onychoscope to take images, along with the nail, you get automatically recorded which nail it is. So this is the right third fingernail. And like that, each nail has its own codified appearance. So later on, once you are taking serially monitoring, so this, you can see how the treatment response has gone, how the biopsy site has changed. So by this way, you can codify the individual nail changes. And always don't forget to take a clinical image. There are different ways of taking clinical pictures. And this is the important of keeping the nails in a proper background right from the beginning. So you get a proper background and you can save it along with the onychoscopy images then and there. So just another example. So in this patient, you can see there is periungual lesions. There are nail changes. So if you put the dots and keep, you can see what all are there. So in this, you can document the periungual psoriasis changes. And here you can see the nail changes very well. These are all polarized views. So that's in brief. Thank you.
Thank you so much, Dr. Jayasree, for that wonderful video demonstration on how to use a handheld dermatoscope. Just one question for you. Dr. Arjun Padakshay wants to know, should we use immersion fluid while examining the nail plate as well? Do you use that on the nail plate as well?
See, not necessary. The thing is, immersion fluid will cancel out further reflection. It will improve the yield of findings. But as I showed, you can get findings even without immersion fluid. But then it's always better to use it as a last step so that you don't you get improved yield of findings.
Thank you so much. So moving on to the last presentation of this session, I'll be sharing my screen. Dr. Jayasree, if you can stop sharing.
Yes. Thank you, Deepak.
So I'll be sharing my screen. I'll be sharing a presentation basically, and the presentation is just a summary of whatever we have learned. So I'll quickly brush through all the slides and all the pictures that we have. So I don't have any financial disclosures, no conflict of interests. So we have learned about the various instruments. We have learned about the techniques, the basics. We have also talked about some of the tips and tricks. And for the features, we'll be discussing in a subsequent talks about what features have to be seen in the various pathologies of the nail while doing the onychoscopy. We have learned that onychoscopy, whenever we are doing, we have to take into consideration all the different parts of the nail whenever we are examining it under the dermatoscope. What's the need? Because it definitely enhances the features which are not visible to the naked eye. And why not use an instrument which is a very non-invasive, painless, easy to learn, and an office-based procedure. So you have an extra hand to kind of diagnose your patients without the use of any nail histopathology. So why not to use it? We also learned that there are certain procedural prerequisites that have to be taken into account, namely the nail unit anatomy, understanding your dermatoscope, whatever you're using, and the use of the various linkage fluids as well. As far as the linkage fluids is concerned, a lot of questions have appeared, and none of the linkage fluid is actually superior in terms of the efficacy, but yes, ultrasound jelly, because of its consistency, because of its the property to stay on the nail plate, is the preferred one. But yes, you can use the immersion fluid, the immersion oils, you can use the ultrasound jelly, you can also use the hand sanitizers. Dr. Ambika has asked, can we use the hand sanitizers? Yes, definitely we can use. It has got an additional benefit that it is going to kind of sterilize the field whenever you're doing the onychoscopy or any dermoscopy. Then we have covered the dermatoscopes. As far as the consensus goes, there is no consensus on the superiority of any device over the other. You can use any of the devices. It is completely on the level of comfort that you have with a particular dermatoscope. But yes, always consider to have a dermatoscope that has the feature of non-contact, and also it should have the polarized light in it. We learned about the various procedural constraints. I'm going to skip them. We also learned about the various techniques that have to be kept in mind. Also, how to clean the nail, and what to do in case a female patient is having nail paint on a nail unit. So how to remove it. We have learned that. We have learned that both the lights, the non-polarized as well as the polarized light, have to be used because they both are complementary to one another. Both of these are going to give you certain features which are going to complement the other light. So always try to use both the non-polarized as well as the polarized light. Now this is the difference how you see in the non-polarized light and in the polarized light. The rule number 2 is always try to examine with the dry examination first, and then if you feel like, and if you suspect that there are certain features which are not visible with the dry examination, always go for the wet examination with the use of an interface medium, which is going to enhance the pigmentary and the vascular features. And this is how the picture changes when you move from a dry examination to to the use of the immersion fluid, certain features, especially in the nail bed, becomes more prominent. So yes, it's a good habit to apply the immersion fluid on the nail plate as well. Certain tips for the proximal nail fold: whenever you're examining, always move from a lower magnification to a higher magnification. And when you are suspecting or whenever you are diagnosing a case of connective tissue disease or any other microvascular disease, wherever you are suspecting certain microvascular changes, always prefer the fourth and the fifth digit. Now, this is the difference, what appears with the help of a contact and a non-contact dermatoscope, which Dr. Jayasree also showed. So certain times there is blanching of this proximal nail fold, which can be avoided with the help of the non-contact dermatoscope. And this is how you remove the faceplate of a DL4, which Dr. Jayasree was also showing. Do not forget the lateral nail folds, because at many times there are certain pathologies which can guide you in reaching to the diagnosis when you are looking at the lateral nail folds as well. So whenever you are examining the proximal nail fold, also take this opportunity to examine the lateral nail folds as well. For the hyponychium, always you have to tilt your dermatoscope, irrespective of the dermatoscope that you are using. Always try to see for the hyponychium as well as the nail plate and the nail bed features with this angle. So as you can see the nail plate, the distal aspect of the nail plate, the hyponychium, as well as the nail bed features, specifically in cases like where you have subungual debris or subungual hyperkeratosis. This also gives you an opportunity to see for the pigment, which we'll cover in the subsequent lectures. We also learned that it is almost impossible to capture the entire view of the nail plate in a single view. So whenever you are looking at the center of the nail plate, there is a tendency that the periphery of the nail plate will go out of focus. Always try to tilt your dermatoscope, always try to shift the angles with which you are seeing to capture the entire view of this nail plate or any other feature that you are encountering in the nail. So it is always preferable to click multiple pictures whenever you are trying to see for the pathology in the nail plate or other parts of the nail unit. Then there are certain aspects that you have to consider while seeing at the nail plate. There are certain features which may be physiological, which may be seen in the children with the aging nails. And then there are features which are quite diagnostic for certain nail pathology. So nail plate surface changes have to be seen. The other thing in the nail plate that you have to see is the color changes, because these color changes again can give you valuable clues towards the diagnosis, whether the pigment is endogenous or exogenous. This type of examination also gives the opportunity to see for the vasculature present in the distal nail bed. Again, a very important feature which we'll cover in the different nail pathologies, where it becomes important to see these nail bed vasculature. And you can see various pathological changes present in the nail bed through this examination. If these changes are not illustrated with the normal onychoscopy, you can always try transillumination onychoscopy, where you can project the light from beneath the nail, the finger pulp, and you examine from the nail plate. So the light is coming from the other direction, and then this way you can enhance features. The indications as far as onychoscopy goes, I think, are increasing day by day. And this is just a very short demonstration. This is just a small table where I've highlighted some of the most important features. But yes, the aspects where we are utilizing onychoscopy in the nail unit is expanding day by day. I'm sure this is going to help you a lot in your practice. Thank you so much.
Over to you, Dr. Khushbu.
So I don't think so we have any more questions. So thank you so much, speakers, for covering the basics so well with the help of live and video demonstration. So now, since we know the basics, what to use, when to use, and some amazing tips, let's move on to the use of onychoscopy in our everyday practice, that is the clinical utility. So in this section, we have divided it into two parts: infective and non-infective nail disorders. So first talk would be by Dr. Balachandra Ankad, who's professor and head at S. Nijalingampa Medical College, Balancourt. Sir will be talking on utility of onychoscopy in non-infective nail disorders. So over to you, sir.
Is it visible?
Yeah, visible, sir.
Yes, sir, it's visible.
Yeah. Good afternoon, everybody. First of all, I would like to thank NSI led by Chandra Guru Madam, Sushil, Tahiliani, and Deepak and team. So my talk will be on utility of onychoscopy in non-infective nail diseases. So I will cover pigmentation and some of the inflammatory conditions. One minute. So sorry for that. So pigmentation can be black or white color. So it's called as chromonychia, and I will be covering melanonychia and leukonychia. And inflammatory condition, I'll stick to psoriasis and lichen planus. So coming to melanonychia. So broadly, it can be divided into longitudinal melanonychia and diffuse. So these are the few conditions I am adding in the list. So longitudinal melanonychia can be due to melanocytic activation, that is benign, and benign melanocytic nevus due to the proliferation of melanocytes present in the nail matrix, which gives rise to benign melanocytic nevus. And abnormal and unchecked proliferation of melanocytes can rise to melanoma. And diffuse blackening of the nail unit can be due to subungual hematoma, fungal melanonychia, drug-induced, and also melanoma can also cause diffuse pigmentation of the nail plate. So coming to activation, so when we do onychoscopy of this type of pigmentation over the nail plate, it gives a grayish background. You should remember that. So whenever there is activation, grayish pigmentation will be there rather than black or brown. So it's always grayish in color, and so with uniformity in the width of the pigmentation and also regularity in the color as well as intensity of the color, and the cuticle is almost normal in case of melanocytic activation. So this case doesn't need any workup. So coming to longitudinal melanocytic nevus, which gives rise to again colored longitudinal bands, which are black or brown in color, and they are uniform in width as well as color and also shape. So you can see here there are linear bands which are very much uniform in width and color, and also this pigmentation goes below the cuticle. So because of transparency of the cuticle, this pigmentation can be visualized beneath the cuticle. Sometimes we may confuse it with Hutchison sign. So it's not Hutchison sign, it is pseudo Hutchison sign. So one should be remembering this. So about onychoscopy of free edge, as Deepak told, we should go in sequence of site of nail unit. So when we do free edge onychoscopy, so this pigmentation, location of pigment in the nail plate, it suggests you of whether the origin of melanocytes, whether it is in the proximal matrix or distal matrix. If it is pigmentation is on the superior side, so it's always from the proximal side of the nail matrix. This will help us to take the biopsy from the nail matrix. Whereas when pigmentation is on the ventral surface of the nail plate, it is always from the distal edge of the nail matrix. So that free edge examination of free edge of nail plate, whenever we get longitudinal pigmentation on the nail plate, so it almost suggestive of like whether the pigmentation start or originates from the proximal or distal nail matrix. So coming to melanoma as compared to nevus, so it has got irregular bands. You can see here there are irregular bands with very prominent pigmentation in the cuticle. It's not underneath the cuticle. It's almost pigmentation of the cuticle, as well as you can see also this periungual tissue is also pigmented. So this is a case of melanoma where we get irregular linear bands, and there will be color variation and Hutchinson sign. So nowadays, whenever we see some signs, we call them under dermoscopy as micro Hutchinson sign, micro Koebner sign, micro auspice sign. So this is micro Hutchinson sign. So what it would be? So here we see linear bands, and the cuticle is again it's pigmented. So what it could be? So let us study in detail. So these are the arrows which are regular and arranged in linear fashion, and cuticle is pigmented here, and these linear bands somewhat they are irregular in size as well as in pigmentation. So here some hyperpigmentation is here, darkly pigmentation. So in such cases one should go for biopsy. One should go for biopsy, but we did biopsy and it turned to be melanocytic nevus. How can we explain this? So this is a regressing melanocytic nevus. Whenever there is a regressing melanocytic nevus, we expect these dots. So we should not confuse with the dots of melanoma or globules of melanoma, which will be irregular and which will not be that linear as in case we see in this image. And also here pigmentation is more pigmentation because of skin of color in our type of skin. So we may get more prominent pigmentation underneath of the cuticle also. So whenever we are in doubtful, we should always go for biopsy, which will prove the diagnosis. Another approach to linear melanonychia, so there can be a width of the band which involves more than 2/3 of the nail plate and presence of gray to black color and presence of nail dystrophy. Whenever we found these features under onychoscopy, this increases the risk of detecting a nail melanoma 3 times. So these factors should be kept in mind. So this is a picture from internet. So here melanoma, nail melanoma, you can see here, this is a entirely covering more than two-thirds of the nail plate, and irregularity of the color and variation in the intensity as well as the width of the bands, and also periungual, that means skin's adjacent skin is also pigmented. So this is a classical case of nail melanoma detected by onychoscopy. So subungual hematoma, it's a collection of blood between nail plate and nail bed. Recent trauma are remembered and easy to diagnose because patients will be remembering, but chronic repeated trauma, especially in old age and diabetics, will not be appreciated. So subungual melanoma always mimics subungual hematoma, should be differentiated by onychoscopy. So subungual hematoma under onychoscopy, one can visualize homogeneous colored areas, round margin or proximal round margin, and sometimes we get streaks or pseudopods. I will be showing the pictures. So here picture of subungual hematoma. You can see here bluish black pigmented areas are there, and pale red area and glazed white area. So this is a glazed white area. So you can see here it's a roundish margin is round, even though we see we are appreciating the color extending from the proximal portion to the distal. So but always that the margin will be round in case of subungual melanoma. One more image. Here you can see splinter hemorrhages, also glazes up can be seen, and bluish black yellow bluish black areas also seen. So one thing we should remember here is round margins and round margins and extending streaks or pseudopods in the distal edge of the nail plate. And this onychoscopy also tells us or suggests us that the duration of the injury. So key points in onychoscopy of subungual hematoma: chronic injury go unnoticed. So onychoscopy helps to differentiate it from subungual melanoma. Recent injury, they show purplish or bluish black areas, whereas older trauma, they reveal reddish brown areas because there is a deposition of hemosiderin. So it appears under dermoscopy as a reddish brown area. And subungual melanoma is a most common DD for subungual hematoma. So inflammatory condition, onychoscopy helps to recognize benign, this is a summary. Onychoscopy helps to recognize benign and malignant and traumatic pigmentation of nail. If more than one digit is involved, it should be thought that it's activation. Single digit adult age should always consider benign and malignant. And we come to know that how these benign melanonychia and malignant melanonychia will appear under dermoscopy. And subfungal hematoma, by onychoscopy, one can know whether it is recent or old, and it can be differentiated from melanoma. Coming to leukonychia. Leukonychia is a whitish discoloration of the nail plate or nail unit. So true leukonychia, pigmentation or the disease arises from the nail matrix. So that whitish areas are seen within the nail plate or underneath the nail plate. So which can appear under dermoscopy or onychoscopy as whitish areas, and it can be striate, it can be roundish, it can be irregular in shape. And pseudoleukonychia is always from the external origin, for example, most commonly by onychomycosis. So here, white areas on the nail plate or with the surface irregularities. One should remember that in true leukonychia, the surface will be smooth. There is no surface irregularities most of the times. And in pseudoleukonychia, surface irregularities, as in this case, can be seen. So in doubt, we can use that blink sign as told by Dr. Jayasree in the previous lecture. Blink sign is nothing but we can toggle the lights of polarized mode or non-polarized mode in between. So this pseudoleukonychia, it will be more apparent in a non-polarized mode, whereas true leukonychia will be more apparent in polarized mode, because true leukonychia, that whitish areas are below, so that polarized mode will pick that portion very appropriately. Coming to inflammatory conditions, psoriasis. So most common nail affection by psoriasis is the presentation of pits. So here, this is an onycholosis part, and pits are there in the proximal portion, and pits they appear as a circular depression, irregular circular depression surrounded by white halo. So sometimes pits can also be seen in various disorders, most commonly in alopecia areata also. These whitish halo or prominent of scales will not be visible in alopecia areata, and also one should use a non-polarized mode to visualize these pits, because they are superficial on the nail plate. So what this proximal nail fold reveal under dermoscopy is there will be tortuous capillaries. Few tortuous capillaries will be there, and also splinter hemorrhage will be there in case of psoriasis. Splinter hemorrhages are nothing but they are the extravasation of blood, and why they take linear shape means because of the canals produced by the attachment of the nail plate and the nail bed. So they are in a linear fashion. So whatever extravasous blood, it takes the root of linearity. So hence the splinter hemorrhages always they are longitudinal or linear on the nail plate or else in the nail fold also. So hyponechium also shows tortuous capillaries and red dots. So hyponechium is also very important to differentiate from fungal infection. For example, whenever there is an onycholysis, we do onychoscopy of hyponechium. So psoriasis will reveal these vascular changes in the form of tortuous capillaries or red dots, whereas onychomycosis will not reveal these vascular elements. So as I told earlier, so splinter hemorrhage is always linear, and also color of this splinter hemorrhage also suggest the time of the affection. Here it is purplish black, probably it's a recent one.
Sir,
So,
I think we hurry up.
Hello?
Sir, I think we are short on time. We need to hurry up.
Okay, madam. So psoriasis in onycholysis, it shows a proximal red band, which is not seen in onychomycosis. This is one very characteristic feature of psoriasis. And erythromatic psoriasis, we can see prominent vascular changes in nail plate, nail bed, as well as in the hyponechium also. So this is psoriasis or eczema. So onychoscopy will definitely reveal the diagnosis. Hyponychium shows red dots and tortuous vessels. So this is psoriasis. So these are the key points in psoriasis. Lichen planus, which has more effect on the nail plate as compared to psoriasis. It shows splits, longitudinal splits, and onychosasia, that is splitting of the distal nail plate. So there are surface irregularities and absent lunula, which are characteristic of lichen planus, and sometimes melanonychia, blackish discoloration of the nail plate, can also be seen in lichen planus. And because of brittleness of the nail plate, sometimes nail plate can be broken, and the nail bed can show splinter hemorrhages. And these are called as white and red alternate bands, which are also a feature of lichen striatus. Whenever we come across like this feature, we should always consider clinical and summation of all the dermoscopic features. And this is a pterygium, which is nothing but a fibrotic band starts from the proximal nail portion to the distal. So onychoscopy demonstrates definitive patterns, and analysis of pigmentation. Scopy, that is the onychoscopy, is always better than the clinical examination, and also it's useful in the differentiation of causes for onycholysis. Thank you.
Thank you so much, sir. I think we're short on time, so we'll take the questions later. Next, we have utility of onychoscopy in infective nail disorders. This would be by Dr. Yasmeen Bhat, who's Associate Professor at Government Medical College, Srinagar. I would request the speakers to stick to the time limit. Thank you. Over to you, ma'am.
Thank you, Dr. Khushbu. I hope I am audible.
Yes, ma'am.
And my screen is also visible.
Yes.
Okay, before starting, I would like to congratulate the Nail Society of India for starting this CME series. Well, today I'll be speaking on the utility of onychoscopy in infective nail disorders. I have no conflict of interest. Well, enough has been discussed about onychoscopy till now, about the procedure and other things. And we know that infective onychopathies are a frequent challenge for dermatologists, and we see them every day in our routine OPDs. And onychoscopy may serve as an important non-invasive adjunctive tool in the evaluation of these infective nail diseases. So for infective nail disease, we can use any type of the dermoscope, whether handheld or USB. But before we proceed further, I would like to share some tips for onychoscopy of infective nail diseases. So if it is possible for us, we should use a non-contact mode, because there is always a possibility of cross transmission, or we can even use the retractable contact plates. Or if we have to use the contact mode, then it's better that the plate should be cleaned with 70% isopropyl alcohol, or we can use some things over the contact plate so that there is no direct contact, like disposable caps or autoclavable contact plates or PVC foot wraps, etc. And it's better, instead of the ultrasound gel, we can use a disinfectant gel as an interface medium, or sometimes we can even use the ointment carton or polythene tube for the USB dermoscope, so that the whole nail unit is visualized and there's less chance of infection. Well, we have mainly the three types of the infections that involves a nail, that's fungal, bacterial, and viral. Now, onychomycosis, we know, is the commonest of the all fungal infections, and it comprises about 40 to 50% of the fungal infections, or rather more the infections of the nail. And we know that many other investigations are there, like KOH or culture or histopathology. But dermoscopy may serve as the first step in the diagnosis of onychomycosis, since the others take time and they may even be negative. So it helps in the prompt and non-procedural assessment of the entire nail unit, and it also detects which patient should undergo mycology. So these are the various clinical types of onychomycosis, and for each of them, we have a specific dermoscopic finding. Now, coming to the commonest one, that is the distolateral subungual onychomycosis. We know that the fungal elements invade the nail from the hyponychium, and the colonization progresses proximally through the longitudinal region. So that's why in this type, the dermoscopic signs share one common pattern, that's the longitudinal configuration. Okay, so whatever we see is all in the longitudinal arrangement. Like if you see here in this image, these are all the striae which extend from the distal towards the proximal margin in a linear manner, but longitudinally and proximally. So it is basically an area of onycholysis because of the subungual involvement, the nail bed involvement, and see the jagged proximal end and the longitudinal striae. So these are the three things which we see: the jagged edge of the proximal margin, then the spikes, which are the sharp longitudinal whitish indentations, and the longitudinal striae, which form the parallel bands of different colors like white, yellow, orange, and brown, which we call as the aurora borealis pattern. So again, here you can see the proximal jagged edge and these striations, and showing the distal margin of the onycholysis. Again, the longitudinal white striations. So this aurora borealis pattern, because of the different colors, it actually corresponds to reflections of the fungal colonies, pigment, and subangular debris. So we can see the whitish, yellowish, orangish, brownish, and blackish color together in the nail, beneath the nail plate. So if we have this distal onycholysis, then a jagged margin with spikes and striae, so we can say with 100% confirmation that it is distolateral subungual onychomycosis. Then coming to the second type, that is a total dystrophic onychomycosis. So there's a distal irregular termination because of the irregular thickening of the nail plate, and a unique type of the keratosis occurs in the subungual area, what we call as a ruin appearance, which defines the indentations on the ventral portion of the nail plate and occurs due to accumulation of the debris. So that basically confirms the downward colonization of the fungal elements at the subungual level. So you can see this distal irregular termination, or what we call as a distal pulverization. So this shows the ruin appearance pattern, right? So you can see here the ruin appearance of the subungual hyperkeratosis in case of total dystrophic onychomycosis. Again, the ruin appearance pattern in case of total dystrophic onychomycosis. And coming to proximal subungual onychomycosis, so till now what we saw was there was a invasion from the hyponychium, but this is a type where there is invasion of the pathogenic fungus from the eponychium. So that's why the proximal nail matrix involvement is there, and it proceeds distally, so that at the distal end there's a linear edge, and what we see mainly is an area of true leuconychia with a linear edge in the distal end. So this is how it appears. It starts from the proximal end as the true leuconychia, and we show a distal edge here, right? So this is how it differs from other types. Now coming to the superficial white onychomycosis, so it is basically a kind of pseudoleuconychia which involves a superficial surface. We can even abrade it because it's a pseudoleuconychia and appears as a friable spots. The another type, that is the endonyx type, because the fungus grows within the nail plate. There's proliferation and branching of the fungal elements, and we can see the classical dendritic pattern here, as has been reported by Dr. Jakhar and others. Now, some studies have shown that there can be a correlation of onychoscopy with fungal culture results. Okay, so we can predict like whether these conditions are fungal culture negative, whether we should go for the culture or not. So it has been seen that the distal irregular termination was significantly more commonly seen in culture negative samples, and so was the black discoloration. But longitudinal leukoleukia was mostly seen in the trichophyton rubrum, and punctate hemorrhages were seen in trichophyton tonstrans positive cultures. And this table from one study showed that there was a significant positive culture positivity in longitudinal white striae, jagged edge, intermittent spiked pattern, and the linear edge. Now, if we have to differentiate, as just Dr. Ankad showed in his presentation, that the onycholysis in case of psoriasis has a proximal red band, while as that in case of trauma has a linear and proximally, but there will be no erythematous band. Okay. And once we compare the subungual hyperkeratosis of onychomycosis, which shows a ruin appearance, to that of the psoriasis, we can see in psoriasis it is more yellowish and more compact, and there's more thickening of the nail plate, as well as there can be seen the capillary changes in the hyponychium as well. Now coming to the fungal melalonichia, which may be present because of some of the dermatophytes as well as the non-dermatophyte molds, and occasionally candida. So the dermoscopy shows multicolored matte black, white, yellow, brown, black pigmentations, but that is usually a blurred pigmentation, and we can see the black reverse triangle. And so these black pigment aggregates histologically correspond to fungal colonies. So what we see here is the pigmentation and the transverse or longitudinal striations, and you can see the reverse triangular pattern. That is, the base is distally and the apex is proximally compared to that of the melanoma. So we can see the irregular matte pigmentation, and so we can see associated leukonychia as well. That may give a clue that it is not melanocyte activation or something like that, but it is rather a fungal invasion. So this image from Chauhan et al. Shows the comparison between melanonychia and the melanocyte activation in the lower images, while as the fungal melanonychia in the upper images. Also, one thing is very important, that once we see in the fungal melanonychia, we can appreciate these yellow colored bands or yellow colored areas. They basically represent the dermatofibroma, which are colonies of fungi surrounded by the polysaccharide coat, and they are usually resistant to treatment. Sometimes even despite giving antifungals, oral antifungals, patient doesn't respond at all. So this may give a clue that the dermatophytoma is there, and we may go for the debridement, whether chemical or physical debridement in such cases, so that the fungal colonies are totally removed. So chronic paronychia, although is a multifactorial eczematous reaction, but we can see that Candida hypersensitivity is one of the causes. And what we see in onychoscopy is like there is complete absence of the cuticle. There is bogginess of the proximal and the lateral nail fold, because they are usually inflamed, as well as we can see the grooves in the proximal nail fold, and sometimes even the distal nail plate is separated. So onychoscopy can also help for the mycological examination. So we know that the best location is the proximal end. So it can help us in taking the samples for the QH as well as culture in the proximal end. Well, the bacterial infections are not many. The commonest one is the Pseudomonas aeruginosa, which usually causes the distrolateral onycholysis and proximal chronic non-tender paronychia. So the color we know is because of the presence of pyocyanin. It's mainly greenish, but which may fade towards brownish or yellowish towards the periphery. Sometimes we can even see the greenish black discoloration. So this is again another picture which shows more of the greenish black discoloration in the nail plate and onycholysis as well. So onychoscopy may also help in monitoring of melanonychia due to infections once it is mixed, not only because of the Pseudomonas, but Candida as well. So once the patients are put on treatment, both antibacterial as well as antifungal, though they are clinically very difficult to monitor, but onychoscopically we can see the results, that how the discoloration disappears, as well as the areas of onycholysis also respond within a period of 2 to 3 months. So this is the image showing that initially the discoloration was dark, this greenish and yellowish. Then later on, see the area of onycholysis is reduced, as well as the discoloration is reduced after 2 months of treatment. Now, leprosy is a condition which may come up with certain nail changes. A number of etiologies are there, like repeated trauma due to neuropathy, and a lot of trophic changes can occur in the nail. So poor vascularity and acro-osteolysis. So all these lead to a spectrum of nail changes varying from pitting, onycholysis, subungual hematoma, melanonychia, onychoscopy, that is thickening of the nail plate, or onychogryphosis, which gives a ram horn-like. Then we may have so all these conditions are because of the trophic changes. Now we can have the brachionychia. That means once the nail is more in diameter in horizontal section compared to longitudinal. So this is mainly because of the acro-osteolysis. Anonychia can also be there, or haplonychia, where the nail plate is very thin that it just breaks down. So all these can occur because of the haplonychia as well as poor vascularity. Booze lines again because of the anemia and less vascularity, though there is reduced nail growth. So we can see the Booz lines, and ultimately nail pallor, again because of the anemia as well as less vascularity. So this is from one of the references. So you can see the Booz lines here, which show the growth arrest in case of nail growth, and the nail pallor, which is very specific for leprosy, has been seen with the help of onychoscopy in the nails of the leprosy patients. So viral infections, we have mainly the herpes simplex can be easily diagnosed with the help of onychoscopy because of the enhanced visualization of the small vesicles, which usually display a grayish or purplish hue. And it facilitates a sample collection for diagnostic tests like Zank smear or viral culture from these vesicles. So we can see it in the proximal nail fold or the lateral nail fold, or even sometimes in the nail bed. Verruca or warts, we know that warts are very common viral infections which may lead to destruction of the nail plate if not treated on time. So the classical finding with the onychoscope is a densely packed papillae, which show the typical red dots. They are the thrombosed capillaries in the papillae, and it is because of the hyperkeratosis, they are surrounded by a whitish hollow. Okay, so like in this image, we can see these are all the hemorrhagic dots surrounded by the whitish papillae. So what we call is as a basal seed appearance, like we see in the skin. So we can have warts at different places, but all of them manifest the same findings. This is a wart in the proximal nail fold. So we can see the papillomatous growths with these hemorrhagic dots and whitish areas around them. So in the sub-ungual verruca is very important because it may initially present as an onycholytic area. So we may have to differentiate it from so many other diseases. So here clearly we can see these hemorrhagic dots surrounded by these whitish areas, which will give us a clue. And so that we may start the treatment initially so that there is no deformity of the. Again, sometimes we have very subclinical verruca of the hyponychium or the periangular areas, so which may present in a different way. But if we diagnose them very early, we can initiate the treatment and prevent the nail destruction. Also, with the help of treatment, whatever we give, mainly immunotherapy or some other treatments, so we can assess the response to treatment with the help of onychoscopy in case of warts. Some other viral infections like hand, foot, mouth disease, we know that they may lead to onychomycosis, and onychoscopy has a role to play here. Like we can easily differentiate it from other conditions. So where there is a separation of the distal nail plate from the proximal nail plate. So onychomycosis can be easily taken up with the onychoscopy. And recently we have seen there have been reports of nail changes due to COVID, like we have the red half moon sign because of the vascular changes, or after a few months of the COVID, because of the stress of the disease, patients have very less growth of the nails, so that they may usually present with the bruise lines. But personally, I have not done onychoscopy in any of these patients, but it may serve as a tool to see the status of the nail changes in case of the COVID patients as well. So this may be one of the new indications which we can add to our list. And finally, there's one condition known as dungiasis, which is due to the sand flea or tonga penetrans. So usually it involves the acral areas just near the nail, this distal end of the nail plate. So sometimes it can be confused with a wart or some other kind of the infection, but with the help of onychoscope or dermoscope, we can easily see that it presents as white to flesh color, light brown nodule like this, with a central targetoid brownish ring and which surrounds the central pore. So this is because of the chitinous sheath of the flea. So this is how onychoscopy helps us in diagnosis of so many infective disorders. So to conclude, onychoscopy is a proven reliable diagnostic tool for establishing not only the diagnosis of the infective disorders of nail unit, but rather it helps in monitoring the evolution, progression, therapeutic response, and prognosis of all these infective disorders. Thank you all.
Thank you so much, ma'am. Thank Dr. Balachandra and Dr. Yasmeen for giving us such illustrative presentations and some very practical points to differentiate infective and non-infective conditions. We'll move on to our next session, which is doing something innovative with our onychoscope. And for that, we have Dr. Ishmeet Kaur, who's an assistant professor at NDMC Medical College and Hindu Rao Hospital. And she'll be talking about intra-operative onychoscopy. Over to you, Dr. Ishmeet.
Thank you, Khushbu ma'am. I'll quickly share my screen now. Is my screen visible to everyone?
Yes, it is. You can start.
Okay. So very good afternoon to everyone. Today I'll be talking about intraoperative onychoscopy, which has really unraveled new gates when it comes to diagnosis, prognosis, and therapeutics of various nail disorders. Now, as we all have learned quite well that the conventional onychoscopy is something which we do through the nail plate. But in certain situations, it puts a limitation to how well we can appreciate the nail matrix and the nail bed features. So that's where intraoperative onychoscopy comes to rescue. We expose the nail matrix and nail bed and we put our dermoscope to this area, to the concerned area. And that's when we can appreciate these features much, much better. So in my talk, I'll be covering about various utilities of intraoperative onychoscopy, a special variant ex vivo onychoscopy, and as a beginner, one may face certain issues with intraoperative onychoscopy. So I'll be dealing with them and how to overcome these issues with various innovations that we now have available with us. So the first and the most important utility of intraoperative onychoscopy is to find the most appropriate site for biopsy. Because many a times when we expose the nail bed and nail matrix, the naked eye fails to find the most appropriate site and to appreciate the concerned features. So you put your dermoscope to the area and you're able to appreciate the most appropriate site for biopsy. In this case, we can see very fine light brown lines restricted to the proximal area of the nail bed and nail matrix, which guides you that this is where you need to put your punch on. Second utility is to make a presumptive diagnosis. Now, not many large-scale studies have been conducted till now, which can lay down guidelines as to how intraoperative onychoscopy can help you in making diagnosis in various disorders. But definitely, we have certain specific, consistent intraoperative onychoscopic features, which can help you in making a presumptive diagnosis. The most important utility in making the diagnosis is when we need to differentiate between benign and malignant melanonychia and also fungal melanonychia. Because like I discussed, conventional onychoscopy may not be able to, guide you as to what is the origin of the pigmentation of the longitudinal pigmentary band you're dealing with. So in the previous case, like I showed, various light brown parallel lines are running parallel to each other, and they're restricted to the proximal part of the nail bed and nail matrix. So this is nothing but, this indicates that you're dealing with benign melanonychia. So not only it will help you in guiding the site for biopsy, but while you wait for the histopathology report, which at times can be, you have to wait for the histopathology report when you are especially in a government setup. So that's when you can prognosticate and counsel the patient and set up an approach in your mind how to manage this case. Now, next is fungal melanonychia, which can again be confusing and can confuse you with malignant melanonychia. But we know that the fungal melanonychia, the pigmentation is exogenous. So when we do intraoperative onychoscopy, what we see is a very unremarkable image in the nail bed and nail matrix. So we don't even need to go ahead with biopsy in such a case. All we need to do is send out a sample of the nail plate for past staining or fungal culture, and that will clinch your diagnosis, obviating the need for biopsy at all. The next case is malignant melanonychia, which can again, you're not able to distinguish from benign melanonychia by conventional onychoscopy. So you have to resort to biopsy, but you put your dermoscope just before taking out the sample, and you will be able to appreciate certain specific features like a very jet, messy looking band with streaks, dots, globules, and pseudopods. And the band is running, extending throughout the length of nail bed, and it is not, restricted to just the proximal part of nail bed or nail matrix, which indicates that you're dealing with malignant melanonychia, and your approach changes even when the histopathology report hasn't come to you yet. The next nail tumor where intraoperative onychoscopy can help you in diagnosis is glomus tumor. Now, this is a conventional onychoscopic picture, and not many of you will be able to appreciate this bluish tinge because of the overlying nail plate. So then again, you have to resort to biopsy. But if you do intraoperative onychoscopy, you'll be able to appreciate ramified telangiectasias, very characteristic telangiectasias present over a bluish background, which indicates that you're dealing with nothing but glomus tumor. Besides helping you in diagnosis, these features can also help you in delineating the margin for excision, which I'll be dealing with shortly. The last tumor is onychomatricoma, and we know two characteristic signs which are seen on intraoperative onychoscopy, that is Sagrada Familia sign and mirror sign. Now, this sign is nothing but when we expose the nail bed, we see on the undersurface of the nail plate that there are certain depressions and crypts present. These crypts resemble the crypts present on a famous monument, that is Sagrada Familia, found in Spain. And corresponding to these crypts on the undersurface of the nail plate, on the nail bed, we are able to appreciate fibrous outgrowths. So this whole complex of crypts and outgrowths is called mirror sign. Now, these two signs are really specific and characteristic of onychomatricoma. Besides these two signs, we can also appreciate non-specific vascular features like sagittal, dotted, and irregular vessels, which can further help you corroborate your diagnosis. Next utility, which I'm going to discuss, is excision of nail tumors. Now, like I discussed, these ramified telangiectasias and bluish background is quite characteristic of glomus tumor. But besides helping you in diagnosis, The abrupt loss of these telangiectasias can help you in delineating the margin of excision and can assure you that the excision has been complete. Coming to the last utility, which is a relatively newly explored utility, not many case reports and case studies have been conducted till now, is to understand the pathogenesis behind various nail findings. So this is one of our case series where we did intraoperative onychoscopy in patients with mottled lunula. And while doing conventional onychoscopy, we found that, through one of the bands of the red lunula, there was a very peculiar linear vessel running. So we decided to do intraoperative onychoscopy before taking out the biopsy sample from this area. And we found that through each of these bands, corresponding to each band of this red lunula, there was a linear vessel running, which gave us a clue that red lunula is nothing but a result of increased vascularity and increased angiogenesis, which corroborated with our histopathological findings. Now we recruited more patients of red lunula and we found that this feature was consistent and repetitive. And in nail lichen planus, that we see that the nail dyschromic bands are present. Again, on intraoperative onychoscopy, we did biopsy from one of these bands, and we found that these bands were corroborating with pigment incontinence and hypergranulosis. Coming to a special variant of intraoperative onychoscopy, that is ex vivo onychoscopy. Now, as the name suggests, here we are not doing dermoscopy in vitro, but we are doing dermoscopy of the excised nail tumor or the excised sample. Now, this helps in three ways. First is that you can appreciate the concerned and the most characteristic feature where you need the sectioning from, which you can mark, and this will guide the pathologist that this is the area which is not to be missed, and sectioning must be done from this area, which will help you improve the diagnostic accuracy of the histopathology report. Other than that, it can also help you in ensuring the complete excision of the tumor. You can do serial ex vivo dermoscopy of the excised sample going from proximal to distal. And as you reach the distal most margin, if you see that that area is free from any suspicious melanin deposition or any suspicious tumor deposition, then this will help you assure that the excision has been complete. Now, intraoperative onychoscopy can appear really complicated, very complicated procedure to many because nail unit is such a small structure and you are introducing a dermoscope while doing a nail surgery, and a beginner may face certain issues with this procedure. One of the most important issue with intraoperative onychoscopy is cross-infection, because you don't want to infect the field of surgery and you don't want to infect your dermoscope because you're going to perform dermoscopy on the next patient. This is even more important during this time of COVID pandemic. So all precautions must be taken to prevent cross-infection. Second issue is because nail unit is such a small structure, stability of the instruments can be an issue. Your field of view can get compromised, and you might not be able to introduce instruments during your surgical procedure when you have a dermoscope put on the nail unit. The last issue is time consuming. It can put a constraint on the time, especially when you have a limitation on the duration of anesthesia and you've tied a tourniquet to the nail unit and you have to do the procedure without wasting much time. So for cross-infection, various spacers, various innovations have been introduced. The very cheap one and very easily available one is a core of a micropore tape, which is easily available in your OT, and it fits perfectly to the rim of your USB dermatoscope. You can put it and use it as a spacer, and you can dispose it off after every procedure. Second innovation is, just like we do our hands, we just glove the rim of the dermatoscope and we dispose it off after every procedure. Third, my favorite is mucilate, which is a wire cage-like structure available on the cork of various wines and champagne bottles. It can be easily procured, and it has many other advantages besides acting as a spacer. It provides stability. It gives you room to, it gives you a good field of view, and it gives you room to introduce your instruments, and can also sort out the issue of field of surgery. Other innovations which can be used as spacers include glass plate, but there's a limitation on glass plate. I won't advise using that because there's a risk of trauma, and putting pressure on the nail unit can compromise on how you appreciate the vascular structures. Other than that, you can use a plastic sheet, a PVC food wrap, a core. You can cut out a piece of 50 cc syringe which can fit to your handheld dermatoscope. You can make a plastic bottle cap as a hollow structure, and again, it will fit to your handheld dermatoscope. Or you can make holes in the rim of the cap of the dermatoscope. So it's time to redefine our approach in nail disorders, especially in cases where conventional onychoscopy fails to help you appreciate the nail matrix and nail bed structures, and you have no option but to resort to histopathology. That's where we need to incorporate intraoperative onychoscopy into our practice. To conclude, intraoperative onychoscopy is an expanding aspect of dermoscopy, which has found immense utility in nail disorders and tumors when it comes to diagnosis, therapeutics, and understanding pathology. But definitely we need for large-scale studies to lay down guidelines and lay down protocol on, and maybe in future these guidelines will be able to help us to obviate the need for biopsy in certain nail disorders. I would like to thank NSI for giving me this opportunity and for organizing this CME, and also Dr. Deepak to help me with the presentation. Thank you. Stay safe.
Thank you so much, Dr. Ishmeet. It was a very enriching, illustrative, and very informative presentation, and something very new. So thank you so much. Moving on to our next section, which is role of onychoscopy in specific nail disorders. And for this, first we have Dr. Manasa KN, who's a senior resident and assistant professor at Kasturba Medical College, Manipal, who would be talking about onychoscopy in onychomycosis. So over to you, Dr. Manasa.
Thank you, ma'am. Good evening, everyone. I'm just going to start off with the topic. So what do we know already? Onychomycosis is fungal infection of the nail unit. And there are a lot of modalities available for identification, but they have their own problems like downtime or separate designated area is required. That's why onychoscopy is upcoming that way. So what we did is a study, which I'll tell about in detail. So we recruited 100 patients with clinical suspicion of onychomycosis. And actually the sample size required was ideally 61 for the precision of sensitivity. And detailed history we took, and then clinical photographs. And then we did onychoscopy with DermLight DL3, which has a 10x resolution magnification. And following that, we did nail punch biopsy or clipping, and DME with KOH mycological culture or histopathology of our pass was done. Either one of these three, if positive, we considered that as a positive case. So that way we got 88 positive cases and 12 negative controls. And then we analyzed. What did we analyze for? Basically, what were my objectives? So these were the 4 points that we evaluated: the prevalence, percentage positivity, and correlation with different clinical types, and the sensitivity, which I'll be coming into the in detail in the next 4 slides. So the first thing is this onychoscopy features, which ma'am has very wonderfully described already. That's the first thing. And so I'll just go on to the next part. So what we can see here is all the features that we noted in our study, as well as in comparison with the other studies here. So we had 88 positive cases, and we had all variants, and spike pattern, like in all other cases also, we had it in high proportion. What we saw was distal irregular termination, which was also quite high. And as we can see, we had all variants as compared to the other studies, and that was one thing. And multiple features were evaluated, which was not done in most of the studies. There are more studies to compare, though I couldn't put them all in one table though. Then the next part of it. The percentage positivity. So the percentage positivity, we can see that I have highlighted only the ones which are in red are the ones which had a positive p-value. That is, it was statistically significant, that is spike pattern, subungual hyperkeratosis, irregular distal termination, and the ruins aspect. And this brings to the next point, that is the sensitivity. So this is a nice table which we identified. That is because we were doing KOH also and PAS also and culture also. This is the order of sensitivity. This hints that spike pattern, subungual hyperkeratosis and DIT can be actually used as a screening pattern for identification of the onychomycosis. Next is clinical pattern versus onychoscopic features. So this was the features which were statistically significant, that is onycholysis, spike pattern, and absence of homogeneous opacity for DLSO, for Rowen's aspect and longitudinal striae for TDO. And the other two variants, we had it in very less number, and endonyx I was not able to identify. Next is about certain things we've identified as new features. That is, one thing is white fluffy shadow, which was cloudy appearance, which was there in multiple layers, and homogeneous opacity and transverse striate trichomania. This was horizontally and in a striate pattern. So there was no specific statistical significance in these, but however, this requires further studies, we believe. Next is something called as lamellar microsplitting. That is, we were able to appreciate horizontal splitting, that is onychoschisia, which was visible only on onychoscopy, but was not visible on naked eye examination. So this was seen more commonly with TDO. And what we also noticed is when we applied ultrasound jelly, this would disappear. The statistical significance was not there. It was on the dot of 0.05, but it was quite a common association with TDO. In conclusion, we also concluded, like most of the other studies, that it can be used as an adjunct, it can be used as a screening tool, but it cannot yet replace KOH culture or histopathology. So you can do this first and then later the definitive investigation. And a few of the limitations of our studies and the previous studies as well. So one is the sample size, and most of the studies like DLSO only was there. And there was negative cases also, which have to undergo nail bed or proximal matrix biopsy and to identify what the cause is. And the negative cases responding to a therapeutic trial was a common thing to see. And the nomenclature of various features were quite different in studies, which kind of puts us into a little bit of trouble. Like here, spike pattern and the jagged margin. So this would be called as a spike pattern. This would be the jagged margin. So, but at what point would you call that so? So based on this, there was one thing which I was checking up and found out that when it was asked to multiple dermatologists, they were still able to tell with comparable accuracy, which makes the things simple, especially when we look forward for further studies, like with respect to like using artificial intelligence or softwares to see serial dermatoscopic images, and even the prognosis, whether certain features have difficult treatment. And of course, we would always want to know what is the difference between candidal onychomycosis and contact dermatitis. So that brings to the end of my presentation. Thank you so much.
Thank you, Dr. Manasa. So next we have Dr. Ankita Chauhan, who's a senior resident at Swami Dayanand Hospital, Dilshad Garden. She will be talking about onychoscopy in nail psoriasis. So over to you, Dr. Ankita. Dr. Manasa, can you please stop sharing your screen?
Yes, ma'am, one second. Sorry, yeah.
Am I audible?
Yes.
Yes, ma'am.
Okay. Thank you. I am Dr. Ankita, and I'll be speaking on onychoscopic features of nail psoriasis. So psoriasis, it has a worldwide prevalence of 2 to 3%, and in India, it occurs in around 1 to 8.8% of the patients. And concurrent nail involvement, it occurs in 30 to 50% of patients. Isolated nail disease is seen in 5 to 10% of patients. Nail biopsy is still considered a diagnostic gold standard, but it is a cumbersome procedure. Hence, nowadays, onychoscopy, which is a quick, reproducible, and non-invasive procedure, it might obviate need for biopsy and also help in post-treatment follow-up. So the learning objective of today's presentation is to evaluate onychoscopic features of nail units in patients with nail psoriasis. So as already many things have been discussed about working of a dermoscope and how do we use it. So I'll go directly to the onychoscopic features of nail psoriasis. This can be divided further into nail matrix features, nail bed features, hyponychium and nail fold features.
Dr. Ankita, can you make it full screen, please?
Is it visible, ma'am, now?
Yes, ma'am.
So coming to the nail matrix onychoscopic features, pitting was found to be the most common feature, and it appears as irregular pores depressions over the nail plate. Other features being leukonychia, red lunula, Bu's lines, lamellar splitting, and fuzzy lunula was the one of the novel nail matrix dermoscopic feature that we reported in our study, and it was found as irregular white lunula. It was seen in 33.6% of fingernails and 4.9% of toenails in our study. Coming to the nail bed onychoscopic features, we have dilated nail bed capillaries with surrounding white halo that are present on the distal end of the nail plate. Other one being distal onycholysis with erythematous border. This erythematous border, as already discussed, it helps in differentiating it from traumatic onycholysis and onycholysis of onychomycosis. Other features being splinter hemorrhages, subungual compact hyperkeratosis, then the oil spot or salmon pest. The middle figure shows it in lower magnification and the extreme right figure shows it in a higher magnification. Coming to the hyponychium onychoscopic features, we have dotted capillaries and the dilated capillaries in the hyponychium. And Arzoo et al. Suggested that hyponychial capillary density is positively correlated with disease severity. Similar dotted capillaries and dilated capillaries were also seen in proximal nail fold and the lateral nail fold. Apart from these features, there are other features that have been demonstrated in other studies. One of them is pseudo-pitting of nails. It was described by Giacchio et al. In 2017, and it refers to presence of pitting only over the oil spots. It is named pseudo-pitting because it occurs because of the involvement of nail bed rather than nail matrix. Other feature being pseudo-fiber sign. This was described by Urelmus et al. In 2017, and they describe it as the red and blue filamentous structures corresponding to arterial and venous ends of capillary remnants. However, these two findings were not found in our study. So, coming briefly to our study, we took 55 biopsy-proven cases of psoriasis, clinical psoriasis as well as isolated nail psoriasis, and a total of 990 nails were studied. That is 550 fingernails and 440 toenails, and the fifth toenail was excluded. Then, in our study, we found that 544 out of 990 nails were involved, and on onychoscopy, 660 nails were involved. So, additional 116 nails were found to be involved on onychoscopy. So, the results of our study, we found that in fingernails, pitting was found to be the most common finding. In toenails, nail plate thickening and crumbling was found to be the most common finding. Whereas fuzzy lunula, which was a novel nail matrix dermoscopic finding, was seen in 33.6% of fingernails and 4.9% of toenails. Amongst nail bed dermoscopic features, we found subungual hyperkeratosis to be the most.
Louder. Please be a bit louder. Please be a bit louder.
Okay, ma'am. Amongst nail bed dermoscopic features, we found that subungual hyperkeratosis was the most common finding in both fingernails as well as toenails. Similarly, in hyponychium, proximal nail fold, and in lateral nail fold, we found that dotted capillaries were the most common findings in both fingernails as well as toenails. This is a comparative table between our study and other similar studies. And as we can see, fuzzy white lunula is a novel nail matrix dermoscopic finding that was reported by us and not in other studies. And among nail bed dermoscopic features, dilated capillaries were the most common finding in our study. So to summarize, the most common feature of nail matrix and nail bed involvement in our study was fitting, followed by longitudinal ridging, subungual hyperkeratosis, dilated nail bed capillaries, and splinter hemorrhages in that order. A novel nail matrix dermoscopic finding, fuzzy lunula, which is described as irregular white lunula, was observed in 33.6% of fingernails and 4.9% of toenails. So dermoscopy could reveal various features suggestive of nail psoriasis in clinically normal appearing nails. And dermoscopy can serve as an early marker of disease activity in cases of psoriatic arthritis, especially when used in cases of clinically uninvolved nails. So to conclude, dermoscopy is a very handy bedside tool for diagnosis of nail psoriasis, and it might obviate the need for nail biopsy in near future. In isolated nail psoriasis, vascular features indicative for nail psoriasis can be appreciated. And when it is used in clinically uninvolved nails, the dermoscopic features can possibly serve as an early marker of disease activity. However, we recommend that further controlled studies on a larger sample size are required to determine specificity and sensitivity of each dermoscopic features and to lay down dermoscopic criteria for diagnosis of nail psoriasis, and to study the correlation between dermoscopic features of nail psoriasis and activity of nail disease. So the take-home messages from this presentation would be onychoscopy should be routinely used in patients of psoriasis because clinically normal appearing nails can show early vascular changes which are suggestive of nail psoriasis on onychoscopy, and it further helps in management of the case. And for beginners to appreciate hyponychium changes, there is only one tip: practice, practice, and more practice. Thank you and stay safe.
Thank you so much, Dr. Ankita. Nice talk. Next in this section, we have onychoscopy in nail LP, which will be taken by Dr. Geetali, Kharghoria, who is the senior resident in the Department of Dermatology, AIMS, New Delhi. Over to you, Dr. Geetali.
Just one small thing I want to say in between. Both these topics were done as thesis topics at UCMS under the guidance of Dr. Archana Singhal, who's the past president of NSI.
Yes, ma'am. Ma'am, I'll just share in a moment. Ma'am, I'm not able to do so. Can you please pardon me?
There's a share screen button. Kindly
Yes,
press on
ma'am.
that.
Ma'am, I'm doing that, but still it's not coming somehow. I don't have the...
Maybe we can we move to the next speaker, Dr. Jayasree, if you're around, and Dr. Geetali can log in from another system. There might be an issue as we had discussed last time.
I am extremely apologetic. Sorry.
I can. Geetali, it happens. You please log out and then log in. It will happen.
Again, yeah. It might help.
It will happen.
Dr. Jayasree, are you there?
Yes, I can take over it.
Okay, fine. So we'll move on to Dr. Jayasree, who's be talking about onychoscopy in glomus tumor. So over to you, Dr. Jayasree. She's a consultant dermatologist at Medical Trust Hospital, Kochi, Kerala, and she's already given us a beautiful talk.
Am I visible, audible? My screen is visible.
Yes, your screen is visible. Just be a bit louder. Thank you.
Okay. Did I lose video now? Hello.
Hello. Yes. There's a your presentation is shown to.
Is it okay now?
So share your screen and
It says I'm screen sharing.
now
Okay.
it's fine.
All right. Okay. So thank you. So welcome back. This is another presentation on the onychoscopy of the glomus tumor of the nails. As we all know, glomus tumors, they are rare, but then 65% of them are found in the subungual space. So a nail unit glomus tumor is something which is not so unconventional. But then literature shows that they remain undiagnosed for a long time, up to 3.5 years. And a patient has undergone average physician visits till a proper diagnosis of it. So how can onychoscopy help in the diagnosis? That is what we set out to study with Dr. Chandir Grover ma'am at the helm. And we were going through the patients presenting with subungual glomus tumor. And conventionally, during literature search, it was found that irregular telangiectasia, that is better visualized and delineated intraoperatively, as the commonest finding. And then there are less than 10 cases so far published with structureless pink areas and occasional disappearance of lunula and non-specific nail plate changes associated with glomus tumors. But then we came across this. So this was a patient who a 30-year-old male who presented with excruciating pain on his right upper limb. And he was actually coming to visit the neurologist for the pain. And that is when they noted the color changes on the nail, and a dermat consultation was advised. So what you can see here are actually alternating bands of localized leukonychia as well as erythronychia, and with a small V-shaped split. So this appearance had nothing to do with the glomus tumors description that was available so far, but the patient did have a nail matrix tumor, which was excised transangually, and you can see a large size lobulated tumor. So what is the appearance that we just saw? That's something called the candy cane appearance, which is classically described in diarrheal disease. There are alternating bands of erythema as well as leukonychia, and this happens in diarrhea due to a matrix dysfunction, whereas in glomus tumor it is due to the compression and vasodilation that is alternatively caused by a subungual tumor which has a lobulated surface, and due to the matrix compression there is thinning of the ventral nail plate, which shows up the nail bed changes further, and the vasodilation is more prominent along with the raised areas of the tumor. So we found that the nail matrix tumors had this characteristic candy cane appearance, which belongs to an ALL, that is acquired longitudinal, acquired localized band pattern. And there were more of nail plate changes due to the matrix dysfunction due to the tumor effect present there. And it is not just the conventional telangiectasias. True as well as apparent leukonychia are important findings that are seen with glomus tumors, more so in the matrix tumors. And this was also associated with the larger size tumors. Whereas the nail bed tumor, you can see clinically it's almost invisible. There is a vague area of bluish and erythematous interspaced areas on onychoscopy. And there, this area of involvement corresponded to the intraoperative size occupied by the nail bed glomus. So yes, irregular telangiectasias can be seen. Structural bluish areas and spots are again common findings of nail bed tumors, but then they are present with lesser nail plate defects. But here there is a change. Here you can see there is a distal onycholysis, and if going by conventional description, you can call this a onycholysis with a band of erythema. But actually, if you look carefully, there are telangiectatic vessels around it, and this forms a masked tumor pattern of clinical presentation of nail tumors. So a nail bed glomus tumor can present as in a marked tumor and fashion, and this is the intraoperative corresponding image. So it is not just diagnosis. What more can we go across through the onychoscopy onychoscopic findings. The features depend upon whether the tumor is present in the matrix on a nail bed, whether it is a smooth surface tumor or a lobulated one, or even about the size, whether it is a small or large tumor. So from our study, we could gather that, yes, erythematous or ill-defined structureless areas may be present, but they are interspersed with bluish and areas. And this usually depends upon the degree of lobulation. And larger the area or broader the band, you expect a larger tumor. And ramified telangiectatic vessels can be seen, but again, they may be poorly focused and associated with a larger tumor surface area. And nail play changes and distortion of lunula is a feature of nail matrix tumors. In the 10 patients we had, 60% of them had nail play changes. And the canticane appearance, a specific finding which was found only in nail matrix tumors. So, and that too, even rarefaction of capillaries can be found in place of telangiectasia in the proximal nail fold due to the mass effect of a larger matrix tumor. So onychoscopy in glomus tumors can diagnose the correct presence, even there are distractors in the nail plate, and you can localize a tumor to matrix or nail bed even without an MRI attempts. In 2 of our patients, the MRI had failed to localize the tumor to the matrix, but we could correlate with the other onychoscopic findings and pinpoint its location, and you get an idea of the tumor size and whether it is smooth surface or lobulated, and you can plan the surgery accordingly. The transangual excision of the glomus tumor, the way you are preparing the patient, the incision, this can be planned pre-operatively using the onychoscopic features and glomus tumor. Thank you.
Thank you so much, Dr. Jayasree. It's a wonderful presentation. So, Dr. Geetali, can we try again?
Yes, ma'am.
So, Dr. Geetali will be talking about onychoscopy in nail LP, and she's senior resident at AIMS, New Delhi. Yeah, it's visible.
Is my screen visible?
Yes, it's visible.
Okay. First of all, I'd like to thank the organizers for giving me this opportunity. I'm extremely sorry it didn't work out first time. I'll be presenting the onychoscopic features of nail lichen planus. What we already know about nail lichen planus is that it involves, nails are involved in around 10% cases, either in association with mucocutaneous LP or as an isolated phenomenon. It can involve any part of the nail unit, although matrix is most commonly seen to be involved. And the thing to remember is that it's a potentially scarring process, so it should be diagnosed as early as possible. And the histopathology remains the gold standard to diagnose nail LP. However, it is invasive and has a low diagnostic yield. On onychoscopy, yes, ma'am.
Full screen, please. Full screen.
Ma'am, just click on this option, use slideshow. In top you can see, yeah, just click on that.
Right?
Yeah.
Yeah.
Yes, go ahead.
Oh, thank you. Yeah, onychoscopy nowadays increasingly being used to diagnose nail LP because it's a faster modality. It can be done in an OPT basis, and it can be repeated also whenever needed for monitoring of response to treatment. And most importantly, it is non-invasive. However, it's a relatively new technique. Therefore, there is a paucity of data. One of the first studies focusing on onychoscopy in nail LP, it included 79 nails in 11 affected patients of clinically diagnosed nail LP, and they summarized their findings as seen here. Subsequently, we did a study where we recruited 45 patients of clinically diagnosed nail LP. We did onychoscopy using a USB dermatoscope dynolite edge model, and we found that 384 nails were seen to be involved by nail lichen planus out of the 900 nails examined in 45 patients. A number of matrix features were seen which were more apparent under the dermatoscope, and the most common ones were onychorhexis, longitudinal melanonychia, and onychoschigia. These are pictures where longitudinal longitudinal ridging, that is onychorexis, onychosygia, as well as longitudinal melanonychia are seen. And these are pictures where the black arrows indicate a very severe involvement of the nail matrix, where there is distal splitting and the nail plate is thin and seen to be tightly adherent to the nail bed, as well as there's a converging nail plate which precedes the formation of pterygium. This is another matrix feature where here we can see a red band which is extending from underneath the cuticle till the distal free edge of the nail plate, and this suggests a matrix phenomena. This is a photo of onychomycosis, and we can see that the proximal onycholysis is extending much beyond, and it's reaching almost till the onychodermal band. These are images of pterygium. In the first one, we can see a very early pterygium, if not looked properly, can be missed. And in the second one, we can see a very well-formed pterygium where the nail fold is seen to be fused with the nail matrix and the nail bed, splitting the nail plate into two halves. Lunula is the most distal part of the nail matrix, and in the nails where lunula was visible, we observed the lunula to see if we can find anything, and we realized that there were features which were seen in the lunula specifically. Those were erythematous lunula, a distorted lunular shape, a flame-shaped lunula, and yellow lunula. We further characterized the erythematous lunula as a homogeneous erythema, where there is a uniform pinkish hue of the lunula, as well as a spotted lunula, spotted erythema, where the white opaque area of the lunula is being replaced by spotty areas of redness, giving a moth-eaten appearance. This is another lunula finding where there is a distorted lunular shape. The lunula has assumed an angulated shape instead of the normal convex shape. This is a triangular area where red areas as well as white streaks suggestive of fibrosis are seen in the lunular area, and we termed it as a flame-shaped lunula. This precedes the development of a pterygium formation. And the last shows here, although the lunular shape is normal, the color is different. It has a yellow tinge compared to the white opaque color. Among the bed findings, we observe findings which has been previously reported, and they were onycholysis, subungual hyperkeratosis, nail bed discoloration, and splinter hemorrhages. We characterized the onycholysis further into regular onycholysis, where the proximal edge of the onycholysis has a very uniform appearance, in contrast to the other picture where we can see an irregular onycholysis where it is a little jagged, like we see in onychomycosis. These are splinter hemorrhages seen in the distal nail bed as well as in the proximal nail bed. This is nail bed discoloration. Here we can see a brownish hue in the nail bed, and in the second one we can see a yellowish hue, and both these discoloration is pairing the lunula. Apart from the conventional nail bed findings, we also recorded some interesting findings which were not previously reported, and we saw linear nail bed dyschromia and nail bed erythema. So probably the nail bed features may be more common than what is conventionally mentioned in textbooks. Here we could find multiple linear parallel bands of multiple colors, like it can be white, black, brown, or red, and they are seen to be limited to the nail bed and not involving the lunula again. And here we can see a patchy area of redness over the nail bed, again not involving the lunula. We also recorded the nail fold findings, and we divided them as cuticular changes, pigmentary, and inflammatory changes. Here in the first picture, we can see a hypertrophied cuticle where the cuticle is much wider than what is normally seen. In the second one, we can see a highly pigmented proximal nail fold. And in the last one, we can see there is loss of cuticle and there is changes suggestive of chronic paronychia. And we can also appreciate a LP lesion on the proximal nail fold. We compared the results of our study to the previously available literature, and we found that red lunula was more appreciated in our study compared to the previous one. Rest of the findings were almost comparable. Melanonychia was not reported in this study, and we found a very high prevalence of melanonychia as well, probably because we were doing in skin of color. I'd like to conclude by saying that the nail bed findings and the nail matrix findings, in these findings, the dermoscope definitely gives a distinct advantage in diagnosing nail LP. Thank you.
Thank you so much, Dr. Geetali. I think this session was wonderful with all the talks, which were very enriching, very good, nice studies. So with this, we move on to the last session, the most awaited panel discussion, where we'll be talking about clinical onychoscopic correlation and how does it help us in our clinical practice. So to moderate the session, I have none other than Chandar ma'am, who's the founder, secretary, and the current secretary of Nail Society of India. Ma'am is professor at Dermatology Department in UCMS and GTB Hospital. She'll be moderating the session. In our panel, we have respected Dr. Archana Singhal ma'am, the founder president of Nail Society of India, director professor at Department of Dermatology, UCMS and GTB Hospital, and HUD Dermatology at Faculty of Medical Sciences, University of Delhi. Ma'am, it's our pleasure to have you in the panel. Our other panelists of the day have already been speakers and have given us wonderful talks today. Dr. Balachandra Ankad, Dr. Deepak Jakhar, and Dr. Jayasree Puravoor, and Dr. Yasmeen Bhat. I welcome you all, and over to Dr. Chandar for moderating the session.
Thank you, Dr. Khushbu. I hope the slides are visible.
Yes, ma'am.
Yes, ma'am. Yeah. Thank you so much. So after having heard so much about onychoscopy, the smallest tricks and the tricks all were discussed in the sessions prior to this. I will be moving on to some real life scenarios, because this is often the question asked, that how does it actually help? So the session now will be a freewheeling discussion on day-to-day cases. So some cases you will think they are so easy. Some cases you may think I have no clue. It will be clinical details followed by onychoscopy with inputs from the panelists as to what they think they want to comment on the basis of what they are seeing. And further, what do they want to suggest, a biopsy or an intervention or therapy? And I request the delegates also to please keep on asking questions in the chat box. We'll take them simultaneously. The goal is to encourage utilization of onychoscopy as an aid by all of you, because of the limited number of investigations we as it is have in the field of nail disorders. This augmented examination actually helps a lot, as we have been seeing over the years. Just day before yesterday or 2 days before, this thing was circulating in social media, that do we actually need dermoscopy? So just in a lighter vein, if you see a nail like this, I've just chosen out a few images just to show how much onychoscopy helps, because it is not just a glorified magnification. It is actually a subsurface visualization. So you can see how much it adds to your perception in a single nail. You can see the dotted lunula. You can see what exactly lies in the nail bed and what exactly lies on the nail plate. Similarly, if this is the clinical view, then this will be the onychoscopic view of that very same nail. And here also, you can actually make out which one is an external pigment, which one is the pigment which is lying underneath the nail plate, and even within the nail plate at what level. So going on to the cases that we will be discussing today, these are very normal cases which you come across daily. A 45-year-old male presenting with nail discoloration and saying that I have pain and discomfort in doing my daily tasks because the nails don't grow very long, but he does not have any skin lesions. So he presents with changes like this. And these are the clinical things that you see. So, because the changes are minimal, because there are no skin lesions, there are no mucosal or any other lesions, then you feel at a loss as to what could be the diagnosis. So we go ahead, do an onychoscopy, and any of my panelists can please cover the findings, because these have been discussed sufficient time in the morning, in the previous sessions. Ma'am, if you would like to start, ma'am. Sorry, Dr. Balachandra, I saw it later.
So madam, please go ahead, madam.
No,
Yes,
no, no,
madam.
no, please. I thought she asked me. It's fine.
Okay, there are linear streaks. There are blood vessels which are dilated and they are linear, and few are prominent above the onychodermal band. So there is more vascular element is there in the picture.
Yeah.
That can be said.
So in the previous picture, you showed that the nails were really cut short because they were breaking. And this is where you see that actually the distal erythema, which was not being seen, is seen now in the form of the dilated vessel surrounded by a whitish halo and onycholysis. This is the disrupted onychodermal band, which Dr. Balachandra was talking about. It has a very regular edge. And this is the lunula of the same, the thumbnails of that same patient.
Early changes of nail psoriasis, I'll say.
Dotted erythematous, again similar pattern, yes. And here also the proximal nail fold. So as we had discussed in the first session, you go from the distal to the proximal. That's just an arbitrary scheme which has been set up so that you don't miss any part of the nail. So once you see the proximal nail fold, you see such a prominent subcapillary plexus in this particular patient. And at higher magnification, this is that same patient going on.
So the tortuous, yeah, Deepak should tell, but there are tortuous capillaries and there are certain capillary proliferation also, branching capillaries. So,
Yes,
and since, but it is a male patient, so I'll be, but still, you know, these changes are not normal, whether it's a dominant hand or non-dominant hand.
This was from the left hand thumb. So,
So
number of, I don't remember which one was his dominant hand, but this is left hand. And this is the tortuosity, excessive tortuosity seen in some of the vessels. So just to summarize, patient presented with pain and discomfort, easy breakage, erythematous patches within the nail bed, erythematous border of onycholysis, salmon patches, nail bed vessels, dotted lunula, and irregularly distributed capillaries in the proximal nail fold were what we saw on onychoscopy, which is augmenting the findings which we could see with our naked eye, leading us towards a positive diagnosis of nail psoriasis. And the biopsy site, onychoscopy in this scenario helps us choose the biopsy site. So any of the panelists are please welcome to put in any more points or which part would you like to biopsy in this particular patient.
So
you can take it from the distal matrix, like the lunula.
Yes, from the lunula, right. And even from these salmon patches, the more well-defined
patches.
Nail bed.
There are more of the nail bed changes, so
But
nail
if
bed
you,
can be taken for biopsy.
yeah, but if you have to take one biopsy, I will prefer it from the lunula.
Right. Thank you. So do we move on to the next case? Just one small thing in between. I was going through the question. So a question was repeatedly asked by 3-4 different delegates. What are the immersion fluids that we use for nail? This has been answered in the first session, but just for a brief recapture, if our panelists could tell us which immersion fluid they prefer to use.
I prefer gel, antiseptic solution, like these sanitizers that come in gel formulation.
Yes, sanitizer gel. This was one specific question. We use it quite liberally because it is now available on all the tables in this.
It's
COVID
easy
era.
to carry.
COVID.
Yeah.
Even before COVID, yeah. It's easy to carry.
Yes, madam.
So Dr. Jayasree had shown us the use of ultrasound jelly. That was for the contact dermatoscopy. She was using the handheld dermatoscope where the lens is going to touch. Dr. Jayasree, you want to talk about that? Yeah.
No, ma'am. I found that sometimes the sanitizer gels are a bit colored, not all of them, but then they may be at, we always have a bottle of ultrasound gel around because of the laser machine. So I keep one on the table always, and it's I have somehow preferred the consistency of the ultrasound gel, which is almost always uniform. So, and it stays well.
So ultrasound jelly is the preferred according to literature also, but that is to be taken in the context of a contact dermatoscope,
Yes.
which a handheld dermatoscope is, because it's a viscous gel which needs to be spread on the area.
Yes.
For the USB dermatoscopes, which many of us are using, ultrasound jelly does not work out well. And regarding the color that you said, we initially had this problem of sanitizer gels having some or the other small balls, colored balls,
yeah,
which you will see in some of my images also. But with this COVID era, past 1.5 years, we have a liberal supply of very good sanitizers, which are totally transparent. So this is another case.
One more, madam.
Yeah,
about ultrasound gel, there are two types. One is bluish and one is colorless. So I would tell the audience and everybody to use that colorless.
Colorless, because
Yes.
I think I also put forward a point that it's a very personal preference. Most of the literature, if you say, it doesn't prefer one over the other in most of the studies. So whatever is easily available to you and you find comfortable with. I started with ultrasound gel, but I couldn't manage it.
But viscous things are usually to be preferred because they stay there and they mask the concavities.
So another similar case of a 24-year-old lady with thickened and dystrophic nails of 3 to 4 month duration. Again, the same problem, no skin lesions. So she has only 2 fingernails and she has multiple toenails which are involved, as you can see. And this one having quite a significant degree of almost lifting up the nail plate vertically. So I'll just go through the dermoscopy images. This is the fingernail. Seeing comments on the border, it's again straight edge with surrounding erythema. More fingernails. This is the toenail. Here we don't see the erythema, but this is the subungual hyperkeratosis of this patient. So how does particularly visualizing, because this is a difficult part of doing dermoscopy, visualizing this end on is a difficult art to master. How does this help actually, the subungual visualization? How does it help in achieving a diagnosis?
Subungual hyperkeratosis, like we can see in many disorders like psoriasis, onychomycosis, or even LP, and so many others like verruca can also be there. But if like in here also, we can see it is very friable in this patient. So friable, we see like we have the ruin pattern and other things that is more specific for onychomycosis. While as in case of psoriasis, it's more compact and we could have more of the thickening of the nail plate also there. So I think for the her toenails were showing more of the onychomycotic features, while as the fingernails were showing more of the psoriatic changes.
This particular is the toenail, the massive subungual hyperkeratosis, as you see here and as you see here. This is the end-on view of that particular nail only, the toenail. So as you can see, it's a massive compact subungual hyperkeratosis, literally lifting it up this thing. Okay. And this is the
there are hyponychial vessels, so it's mainly psoriasis.
Dotted vessels, yes, very rightly said. And at higher magnification,
they look lobular also.
Yes, the glomerular loops, which you can achieve with the USB dermatoscope, where you can see actually the knotted nature of these vessels. So to summarize, it's an isolated nail involvement again, marked inflammation in fingers and relatively long-standing changes in the toenails, more of subungual hyperkeratosis in the toenails and more of erythema in the fingernails. And but the onychoscopic features taken as totality from all the nails examined go again in favor of nail psoriasis and can help you identify the biopsy site in this particular patient.
There was one more point. When there was subungual hyperkeratosis, though it was very friable, but there was no irregular termination of the, you see, it's a very regular thing on this thing. So that point goes against the onychomycosis.
Yeah, here. This very regular domination
Yeah,
of
so
the nail
that
plate.
you showed on the dermatoscopy of the subungual SUH also.
Yes.
So that again shows.
Another very subtle feature in the subungual hyperkeratosis were the dark red to black dots also. If you see near the nail bed. So mainly when the subungual hyperkeratosis is involving the nail bed, these red dots may appear. Whereas in case of onychomycosis, since the nail bed as per se is not involved, the appearance of these red dots will not be visible in onychomycosis.
But this is very contradictory, I would say, because since it's a toenail, there can be trauma induced also.
Yeah, trauma induced.
We know the sign, the pseudofiber sign also due to the trauma and other things.
So all our panelists are on the same page. Now let's go on to the next case. Sudden onset pain with the single nail involvement, a case shared by Dr. Yasmeen. So this is the clinical picture. Not much can be seen of the thumbnail, but on putting here an microscope, this is what you see.
Splinter? Wooden splinter?
Dr. Yasmeen, if you can tell us what exactly was this?
Yeah, see, you could we could see a focus of this pus here. So patient was having pain because of this, and like sometimes if we see this clinically also, we may even think of herpes or something else, a lot of pain and vesicles or even pustules. But once we use the dermatoscope, so we can easily see that there's a foreign body which has led to this pus formation there.
So the clinical clues being the sudden onset and the painful nature involving a single nail with a clearly visualized body and visualized effects of its presence also. And here I would just like to say that the removal can also be guided by, should also be guided by onychoscopy.
Onychoscopy, definitely.
Yeah, again, and we have these interesting tools being published in literature which can be used to do a procedure under guidance of onychoscopy, be it the skin or the nail. Right. Second, the third case with a single nail involvement, asymptomatic but present for a long period of time, and yellowish discoloration confined to one side of the nail plate with some thickening associated. So this is the clinical picture. You can see some discoloration here, and you can see the thickening here. And these are the onychoscopic pictures of this particular nail, again shared by Dr. Yasmeen.
Onychometricoma?
Yeah, single nail, asymptomatic, long duration, probably
Xanthonychia plus wood grain appearance.
Yeah. A very interesting thing about this patient was that she didn't marry. She was 40 years old. Just for this, she has went around 13 hospitals from Chennai, Hyderabad, Kashmir, and she was so much obsessed with it, and that she's not even married.
So
and
kudos to Dr. Yasmeen for solving the long-standing.
Then my husband's orthopedician, so he just removed it, and ultimately the biopsy came to be on onychometricoma.
Yeah, it is
a fibrous tumor.
Thanks for outlining this. Contrary to what dermatologists may believe, the impact of nail disorders on patients is quite high because it is a
This is so amazingly high.
Yeah, absolutely. And the pain with which they live in. So this is the typical woodworm appearance of onychometricoma, which is visible on the distal end. And you can, the clinical features in this case were the longitudinal xanthonychia, single nail involvement, asymptomatic, yellow discoloration with longitudinal white lines present within, and a free edge showing a honeycomb appearance. So diagnosis of onychometricoma, treatment, surgical removal. Another case in a 45-year-old lady this time who presented with a dark thick band involving the middle finger, again asymptomatic, and came with the problem that I can't cut my nails. I have difficulty in cutting this particular nail. So this is the clinical picture, no symptoms, and going on for the past 10 years or so, 8 to 10 years she said. And this is the onychoscopy, the surface image. Then followed by, this is the proximal nail fold location, which is showing, and the distal edge, and again, end on
pigmented onychometricoma.
Yes, pigmented onychometricoma. So irrespective of how it wants to fool you, here you can actually see with the help of
xanthonychia. Yeah. And you can see the splinter hemorrhages also, which are very pathognomic of
Exactly. And you can see the longitudinal white lines, none of them running through the whole length because they are tunnels of the tumor. You can see the very visible proximal nail fold swelling, almost a pterygium kind of a presentation. And here you see the distal edge of the same tumor. We actually took a clipping and did a onychoscopy of the clipping, which will show you the woodworm appearance. So again, onychomatricoma can be longitudinal melanonychia also, but then the clues are hidden within that black. And it is a pigmented onychomatricoma warranting surgical removal. Then another patient with thinning and distal splitting of multiple nails with fingernails involved, brittle nails and discoloration. This is the patient. I'm sure many of you face such things where you have 5, 6 nails involved and then you keep on putting the clues together. So onychoscopy actually adds up to the number of clues that you can glean from your patient. So here, anybody would like to comment something? Otherwise, I'll move on to the onychoscopy.
Scopy, madam.
Scopy. Okay, so this is the first nail. Where you see this one is a hazy picture. This one you can see the second
lichen planus.
The second nail, the third nail. Enough clues for ma'am already. The fourth nail and the fifth nail, sixth nail, seventh.
Lichen planus because there is pterygium formation.
Okay, one small pterygium here. The onycholis is here with a regular border, and you can see the nail bed. Erythematous lunula, and except for this splitting of the nail. Yes, distal splitting. Onychorhexis with distal splitting. So the polydactylous longitudinal erythronychia, commonest inflammatory cause being lichen planus, multiple bands were seen, and along with that distal onycholysis, longitudinal nail bed dyschromia make your diagnosis easy, help you identify the biopsy site also. Next, asymptomatic growth involving a single digit again in this particular thing. And here I'll share the onychoscopic picture also. Again, Dr. Yasmeen's case. Would you like to enlighten us about the...
Yeah. So this patient had history of 3-4 years. So initially, once we saw clinically, we thought of a wart or some kind of like myxoid cyst or something. But once we put the dermatoscope, it was a clear this garlic claw appearance, very characteristic garlic claw appearance. With this like whitish areas, structureless whitish areas, indicative of some fibrosis underneath, and these are some purplish hemorrhages, maybe because of the trauma of the foot. So this gave us an idea of fibrokeratoma.
Yeah, and a very typical keratotic tip for this tumor. Arising from underneath the proximal nail fold and having a very typical keratotic
fibrokeratoma.
Acquired digital fibrokeratoma, asymptomatic growth, and again surgical removal is warranted here. Another patient presenting with pain and swelling of the great toenail, and this is the finding here. Case contributed by Dr. Jayasree. If you can tell us
Annuloma pyogenicum.
Onychoscopic features seen here.
Yeah, because there is a rim of epidermis.
Yes. Along with?
Like a railroad track we can't see in between, but
it is not there.
There are some white
streaks. It's a vascular
and white areas. Yeah, homogeneous pink structures, homogeneous red structures, white colorate. But that white septae are not visible in this case.
It could be quite advanced, like
It's freshly ulcerated also, I suppose, because of that.
It's secondarily modified.
Yes, madam.
Pyogenic granuloma in this location could be a result of ingrown toenail that needs to be kept in mind. And other than that, this particular lesion, even if there is no ingrown and you're not planning to do the whole lateral nail matrix mineralization, this lesion needs to be treated as a pyogenic granuloma. Right, going on to the next case, which is reddish discoloration of the nail of long standing, producing a depression over the nail plate with partial thickening of the nail plate also being seen in that ridge pattern. So this is the single nail which is seen, and this is the dermoscopic picture.
Onychopapilloma? I want to ask Dr. Yasmeen, did patient allow it to remove? Because I've seen so many cases, nobody is ready for surgical excision.
This patient actually came with severe pain, and because of this erythronekia or pinkish hue, we thought maybe it is because of his pain, we thought it is maybe glomus tumor. So we got an MRI done, but that was not showing much of the vascularity. And from the dermoscopy, only then we could think of onychopapilloma. But ma'am, you are right, he didn't come for the excision, but
nobody
but
comes. Like I've seen more than 10.
Erythronekia, and this, we had one more dermoscopic image, so it was more in favor of onychopapilloma.
So this is one typical from an article, and this is the summary for this particular case, onychopapilloma warranting a surgical removal. We have a question from the audience. Do we need both handheld and USB dermatoscopes for clinical practice? Sorry if we are giving you that impression that you need both of them. We are actually giving you the differences between both of them, so you can choose according to your particular requirement. So people who are actually wanting to look at nail fold capillaries can go in for a USB dermatoscope, which gives a much better magnification. But for all practical purposes, handheld dermoscopy is good enough. For all the conditions that we have been discussing till now, it can give you very valuable clues. So, but this way or that way, just decide and buy and start. Right. Another case, a 50-year-old lady with a painful thumbnail, longitudinal reddish discoloration, distal nail split and loss. So this is the patient who came with again single nail involvement. Okay. This is the clinic. This is the first onychoscopic picture. This is the one with a handheld dermatoscope, as you can see on the side. This is the one higher magnification with a USB dermatoscope. Here you can see the typical white and red alternate lines.
Darius. White and
appearance. And interesting.
This is very painful, no, Dr. Yasmeen?
Yes, very painful.
So Derriere will not be painful.
Okay.
And plus it is a very localized one single long.
Yeah, and it's leading to nail splitting, which does not happen in case of Derriere's.
It's a distal
striatus, probably striatus, alternate red and white.
This is glomus.
Glomus, okay.
This is glomus as outlined by Dr. Jayasree initially, the candy cane appearance in a very localized location in one single nail. And please note this typical rarefaction because of the tumescent action of the tumor. What is basically important here is, even though this is a distraction, that probably the problem lies here, the problem lies here, where the longitudinal erythronekia band is arising, and you have sufficient clues in onychoscopy to go there. Obviously, the best localization for a glomus is the patient herself or himself, because of the pain test, they can actually tell you the location of their tumor in the best fashion. So monodactylous longitudinal erythronekia accompanied with severe pain and distal splitting. And these are the onychoscopic features which on correlation lead to a nail matrix glomus. It's a matrix location. So be ready to pull up the proximal nail fold. This was where the tumor was lying, this particular patient. Another patient, again with pain thumb with longitudinal reddish discoloration, distal split and loss. I'm sorry, the clinical description got pasted for the previous case. This is the patient, another patient again with single nail involvement with severe pain, not longitudinal, but a large erythematous kind of a swelling producing distal onycholysis and you can see some degree of lifting up. Again, pain is severe.
This is nail bed glomus.
You see the number of vessels which are poorly focused lying underneath, and you see the regular edge of the onycholysis. So this is this large lesion, which is a nail bed glomus, as you can see here. Once it was excised, it was a fairly large lesion. Then a 40-year-old man with recent onset darkening of the great toenail, complaining of darkening of the nail fold as well. Now this is a common complaint with which patients now come to us because they Google too often, the longitudinal melanonychia. So this is the clinical picture and this is the onychoscopic picture. Comments?
Nivas, age kya? What is the age? 40. Okay, sorry, I missed. 40-year-old male is definitely settling in. So
It
here,
looks more.
so this is nevus.
Or
Tan color without any.
Basically, the color is uniform,
brownish.
light brown
Parallelism
color.
is maintained.
Parallelism is maintained. It's
And
a
color
regular
is brown.
Yes.
At the proximal nail fold, please, because this is again an audience question.
Because nevus arise from the
matrix.
end on. Can you show us the end on picture also?
Sorry, that I don't have.
Okay.
I'll have for more, and I'll have for the.
And there is pigmentation of the proximal nail fold as well.
Yeah, there is.
That is constitutional or.
Yeah, so that is the question, no? Whether this is Hutchinson sign or not, because this is often they come worrying about this, whether this is a spread of pigment into the proximal nail fold, which
Dr.
is
Chandar, this is too wide and it is all along the proximal nail fold, entire nail fold. And if it is men, like there is frictional melanonychia also of the proximal nail fold because they wear
more brownish
shoes. Yeah, it's brownish. So
actually the proximal nail fold pigmentation doesn't appear to be related at all to the band that we are talking about. So this is probably a benign longitudinal pigmented band, could be frictional in origin as ma'am said, or it could be any other melanocyte, reason for melanocyte activation in that area. And for this patient, we'd be comfortable telling them to wait and watch and to come for repeat onychoscopic evaluation after a time period. Another patient here, this one is a 32-year-old woman with recent onset darkening of the thumbnail, complaining of the nail fold also. This is where she's bothered. So for her, you have this onychoscopic picture. And
I think I'll go for a matrix biopsy because this is very irregular.
Variegated color and
Variegated color.
positive Hutchinson sign.
Yes, so this is a
and this is arising from the proximal matrix because you can see the the ventral aspect of the nail plate is involved.
Yes, so this is the worrying aspect. Here you can call it Hutchinson sign, and it needs to be explored further. And possible diagnosis could be malignant. I did a histopathology; it came out to be normal. No, but it was a melanocytic nevus, but it was not. There were no signs of malignancy. Again, histopathology may cause confusion. That is topic for another CME
discussion.
Maybe. Yeah, but this one was benign and it went on to, regress after removal. Another case, again, staying on the topic of pigmentation only, this one a 47-year-old male who had been very meticulously tracking his pigmentation over a period of 1.5 years, showed me all the photos which he had kept in his mobile. And this is his dermoscopy with the handheld, and this is with the USB dermatoscope, higher magnification. Here, comments of the panelists, please.
Again, benign.
It could be nevus. There's no Hutchinson sign, and there are quite parallel bands.
Yeah, quite parallel bands. So the essential features of this being benign being all the parallel bands, no variegation, no crisscross lines, and here the proximal nail fold pigmentation appears to be pseudo Hutchinson sign. Yeah. It's just the pigmentation visible through a transparent cuticle rather than actually involving this area. And this is the distal edge, again with a handheld dermatoscope and with a USB dermatoscope. So it's a large lesion which is lying in the matrix. That is why it is producing a through and through blackish discoloration of the whole nail plate. It is extending from the proximal to the
distal nail matrix. Yeah.
And as you can see, intra-operatively also, it's a large lesion and with a regular striate pattern and no signs of any variegation or spread to the surrounding area. So to summarize, asymptomatic, no spread in the proximal nail fold, but there are regular and the onychoscopic clues added to that will help you consider what is to be done. The patient wanted its removal because he'd been very obsessively tracking it for long, and the biopsy came out to be normal.
nevus without any signs of atypia. So just staying on the topic of melanocyte activation versus melanocyte proliferation, these are the 2 or 3 key findings that activation is going to be gray in color, whereas proliferation tends to be black, more jet black. With a regular pattern, you can assume that this is a benign proliferation, but any irregularity, either in terms of width or in terms of the extent of the lines or in terms of the variegation of the color, should make you think more in terms of whether you should explore it surgically. Some more cases again with pseudo-Hutchinson sign. This is so clearly pseudo-Hutchinson sign because it remains confined to the band itself. And it's a child. So all the more it is visible, even through the nail fold, it is going to be visible. In adults, it is only through the cuticle, but in a child, it may be visible through the nail fold, causing even more apprehension to the parents. Moving from the topic of melanonychia, a 44-year-old lady with single nail whitening progressive for months. Again, one single nail involvement. The patient was on immunosuppressive therapy and only one nail is involved. This is the
SWO. But it is going to TDO actually.
Homogeneous.
Onychoscopy.
Clouding.
Onychoscopy.
Okay, it could be even endonyx because it is showing the dendritic pattern, or we have to rule out even superficial at other places.
It can be mixed variant. Yeah.
Homogeneous, that could be superficial white, but because of this dendritic pattern, it could be.
So where it is very uniform white, it is very difficult to make out the details. But once you move towards the edges, you can clearly see again it's a dendritic pattern. And because of that, keep a possibility of endonyx onychomycosis actually going to TDO only. And once it goes to TDO, it is going to involve the nail bed also. Although classically in endonyx, it is an infection proliferating within the nail plate. Another case of a 44, again, this is a wrong description. I'll go to the case only. This is a younger female, 24-year-old with involvement of multiple toenails, only toenails. And you can see the onychoscopy.
Trachonichia.
Onychoscopy.
Is trachonichia?
Onychoscopy.
Superficial white.
Superficial white. Only the
This is trachonichia.
Great pattern.
Only the toenail. Okay. You said 20 nail, I thought.
I said only
toenails.
Yeah, and 24-year-old lady, I said. And this is the proximal accumulation of the scale. As you can see, it is more proximally. And then involvement of the superficial part of the nail plate and a grid pattern. And this is where you can actually toggle between the polarized and non-polarized part of your
pseudo-leuconychia.
Where this is the same image taken without polarization on the left hand side, where you see all the surface irregularities, and as soon as you move to polarized or you put in a interface medium.
I will also keep a possibility of keratin granulation in this patient because it is very diffuse. And there are other nails, like even the second toe has the similar thing. So maybe she is using the nail paint remover too much.
All the nails, all the 10 toenails are involving, including the little fingernail also. This particular patient did not.
That's what I'm telling you.
This particular patient did not give history of this thing, nail paint application and removal. And plus, this was confirmed on QH microscopy. The only point here is that it can be treated with topicals initially if it is entirely a superficial white onychomycosis, which we did, and it showed improvement. But depending on, it'll need a longer term of follow-up. Then one more standard indication for onychoscopy, which Dr. Ankad had discussed again in the morning, multiple causes of onycholysis. Which can be differentiated with the help of onychoscopy, as Dr. Yasmeen had also discussed. Onycholysis of various causes, I'll just be showing the clinical and the onychoscopic picture. So this is one lady.
DLSO.
Yes, onychomycosis. Because of the jagged pattern, you can see
spikes.
And the spikes which are present. Another case, 17-year-old girl this time, multiple fingernail involvement.
This is, these are
It's
the
traumatic
psoriasis
because it is too bland. There is no proximal erythematous border, so it is probably overzealous manicure or
one missing possibility which can be kept post-traumatic onycholysis.
Yeah,
although
that's
she
what I
had
said.
a big loss of nail here to quite an extent. This patient, I just wanted included the images, though they are not very typical, just to highlight that in many cases when you are suspecting psoriasis or you have evidence of psoriasis, there you may not see the typical erythematous border, because for that the disease has to be active in that toenail. So only mild erythema seen here. And as ma'am said, you have to rule out overzealous manicure and the tendency to clean under the surface of the nail plate as a cause for this onycholysis, which is a traumatic cause for onycholysis in this particular patient. So if you see something so so bland, then it might be that because the disease is right now not active, which does happen, as I showed in the first case where the toenail was not showing the erythematous border, but was showing the compact subungual hyperkeratosis, and the differentials have to be discussed here. Another one, case of onycholysis, 18-year-old female, again involvement of multiple nails, and you can see here, this is the henna pigmentation, so it is obliterating things which can be seen under, but this is the onychoscopy of the two nails which we could see without. This is a case shared by Dr. Jayasree. I'm sorry, I didn't put the name here. So here you see onycholysis again with a regular edge, and Dr. Jayasree.
White lunula, I can see.
There is some amount of linear bed dyschromia as well. There is regular bands.
Yeah. Lichen planus can be a possibility.
Lichen planus.
And then
because you see DNB also, like disappearing nail bed, also there is epithelization of the nail bed, which quite frequently happen.
And you see, melanonychia is a very constant accompaniment of lichen planus in our skin, though it is not that much described in literature, but many of our cases we tend to see a lot of melanonychia which is present in the patients. One, I think this should be the last case. Another patient, 28-year-old male, single nail onycholysis, came for onycholysis. Came that my nail is separating from, nail plate is separating from the nail bed.
This is post-traumatic hematoma and then secondary onychomycosis. This is pretty common.
Denied history, but so much of blood tells you it is post-traumatic onycholysis. Separation, you see.
And then proximal, or now it is DL. So like, but there can be like PSO is also very common secondary to hematoma formation.
That is in the long term. Generally, when you have an exposed nail bed, it is likely to become secondarily infected. And here you see the regular edge, and you see the presence of multiple small hematomas. Here they have started changing color. Here they are still appearing more
in
fresh.
The proximal part. You see stride micro leukonic this thing micro splitting also.
That was separation. The nail plate was getting separated. So it could be a repetitive trauma also, because you see multiple ages of the blood with different stages of resolution. So it could be dependent on the footwear or the occupation or the hobbies of that patient. So these are the subtle clues which you can derive from onychoscopy. Another picture of that same patient. So proximal separation of the nail plate has also started occurring. So clues towards onycholysis could be fungal, psoriasis, lichen planus, traumatic, as we have discussed. And these subtle things can, because with nail, it's always a limited number of reaction patterns, and the combinations take you towards the diagnosis. With this, I close the session, thanking all my panelists.
Thank you, enjoyed a lot.
Thank you, madam. Learned a lot.
Chandran, there are questions, if we can.
I think maybe there is one question. Clinical diagnostic test of ice cube on the painful nail aggravating the symptoms can be additional help. Definitely, it is a big help, and helps you localize the tumor. This is the classic cold test, which is helpful. Any other question that anyone can see?
There is one by Dr. Shikha Bansal. She's asked, Dermlite 4 is now coming with conical attachment for better visualization of nail unit. So anyone has any experience with that?
Not yet. The ones buying new can definitely have this onychoscope attachment and let us know. We'll await from Shikha.
Okay, ma'am. So there's one more for non-USB dermatoscope, how to put tape or other measures to prevent cross-infection.
Okay,
Put
I
the
think
food wrap.
we can start on this.
PVC.
The different methods.
You can also you put this mobile screen cover. You can put mobile screen cover also, which you can change after a week or after single this thing. So you can have them in circular shape, and then you can use it and discard it.
Right. Thank you.
One more question is, what is the cost of an onychoscope and which brand to purchase? So cost of an onychoscope, if you want a good one, either category will be approximately near 1 lakh or slightly crossing 1 lakh only. The handheld ones as well as the USB dermatoscope ones. So first you have to decide what you want to purchase and then go ahead with that. So I think we've taken the questions.
There are few coming right now. So turmeric coloration of nail plates, how to remove while in clinic before an onychoscopy.
How to remove what?
If there is a
Turmeric coloration
of the nail plates.
Turmeric coloration.
Yeah.
I think
you
we have to wait for that to grow off, like we have to do it for henna. There is very difficult to remove with repeated washing only. I think turmeric will not be as long lasting as henna or as the discoloration produced by repeated use of nail paints, but it doesn't clear completely. So some time will have to elapse before you can do a complete analysis.
Sushil wants to ask that how would you treat case number 1?
Case number 1
we
was,
have to go back to case number
case number 1 was nail psoriasis, the one presented. Limited nail involvement and minimal changes, mild erythema in the nail bed. I could ask the patient to, start using topical steroids at the distal nail edge, because the changes were very less and would not justify the use of injectable therapy or oral therapy. Plus, it was confined only to the nail plate. The main confusion, the main complaint that the patient came with was slight pain and discomfort and nails breaking easily. So that can be helped with the use of topical steroids over the distal nail fold.
Right. And I think there's one last question. Is overzealous manicure present in males? So panelists, if they have experience. I think that's the last question.
Wait, lots and lots and lots of emollients. Nothing can be done. It will grow out. Emollients are very essential, because if you keep it dry, then the nail bed tends to get epithelialized, and then it will not stick even if the nail is growing.
Yeah. So yes, overzealous manicure can happen in males also. There is nothing stopping them from cleaning their nails with a lot of vigor, and but though it is commoner in females for sure. So with this, we come to an end of this first CME, and just to briefly, I've just put up the poster of the next CME. Over to you, Dr. Khushbu. Thank you to my panelists.
Thank you so much.
madam.
Thank you. Good cases, good collection of.
Thank you so much, ma'am.
Very interesting. I think wonderful cases and all compiled too well. So I think we really enjoyed the last session. So with this, we come to the end of this CME, and to mark the end of it, I would invite Dr. Vineet Relhan, so sir, if you could give us the closing remarks.
Good evening. It was really very good, brilliant cases by Chandar, and all the talks were really comprehensive, very, very informative talks. And at the end, we'd like to thank the Linux Labs. They have tied up with us for this skill-based CMEs, and today was the first one. And I'm very thankful to the Linux Lab. They're very cooperative staff. In the last moment, we changed the platform to Zoom. After many speakers said we're fine with their platform, and they changed it in the last moment. So thank you so much to the Linux Lab team, especially Venkat, Ashish, Namita. And next CME would be next month, I suppose, on the nail biopsies, as Chandra has already told. And today we had around 400 plus logins. So that's a very good number for the CME, 400. And you can see all the updates on the social media, as well as we have put up a page on our website, nailsocietyofIndia.com. So you can check it regularly. And with this, I thank everybody for joining in and Linux Live for collaborating with us. Thank you so much.
Thank you.
Ma'am, I think we are done and we can call it a day.